All right, welcome to everyone joining. We're going to start in about 3 minutes. And it's our tradition here when we're kind of just getting started in the morning. If you can leave in the chat box where you're coming from, where you're watching from, that would be fantastic. You can say a state or a city. And that also tells us that the chat box is working. And it is great.
Yeah, perfect. Good morning, everyone.
Hey, Kyle, how's it going? Las Vegas,
Good
Houston,
morning.
Ontario. Yep. Yeah, feel free to just leave where you're watching from. That'd be great.
Dad, are you going to share a wedding photo? We need a wedding photo, man.
Oh, I will sometime next week.
I got Vegas representing
Good
today.
morning, Jill.
Colorado
Hey, Eric.
Springs.
I don't know where Smiley Face is from, but Dallas Fort Worth.
Texas.
I like it. A lot of Texas representing today.
Yeah,
And
perfect.
there's an Alaska one as well.
Yeah. Cape
All
Cod,
right.
nice.
So just a friendly reminder to everyone to basically change your chat box to everyone, okay? Instead of hosts and panelists. Yep, there you go. Perfect. Scottsdale, nice.
San Francisco, yeah.
California, he said.
Hello to Raymond. I think you've been to every single one of our CE events.
I
Appreciate
think
it.
so too. Hey, Amanda.
All right, we will start in about 2 minutes. So once again, if you're just funneling in, open up the chat box, tell us where you're watching from. Montana, great. Yeah, I was just there last month. Fantastic place.
I love Ohio, yeah. Seattle.
Yeah, we're getting pretty good representation across the US. Pennsylvania.
We have not a Julia fan, but we have a Julia fan.
Another San Antonio.
Sugarland.
Sugarland, yeah.
San Diego's beautiful right now.
Portland, awesome. All right, we'll start in about 1 minute. So everyone funnel on in. Let us know where you're watching from. Texas is represented today.
I think Texas is in the lead so far. Huh?
Yeah, normally it's
Right.
California or New
Home
York,
state.
but yeah, I think it's Texas. I guess y'all have a lot of myopia over there. You got to control. So. All right, fantastic. Well, it is 9 a.m. our time and 12 p.m. on the East Coast. So I'm going to go ahead and get started here so that we run on time throughout this fantastic event. We've got 3 great speakers for COPA-Proof CE, and we also have a special speaker in between that's going to give us a 10-minute talk. And before we get started, I just want to put a few intro slides out there. Number 1 is ODsonFinance Careers. If you haven't checked it out yet, please do, whether you're looking for a job or you want to hire someone for your practice. Scan the QR code right there. If you are looking for a job, make sure to make your candidate profile. It's absolutely free. You can upload your resume, your photo. It's basically like a small LinkedIn for the optometry community. And if you're looking to employ someone or if you're looking to sell your practice, we've got the lowest rates out there. And we've got a bandwidth of 15,000 optometrists that are looking at this. So you've got a great community that you can reach out to. And the other thing is we've got another event coming up. And so part 3 of Steve Alexander's On the Path to Your Predominantly Private Pay Practice, which is a tongue twister in itself, is happening September 11th. And we're really diving in here. Session 2 is fantastic. Actually, Chris Lopez led that session and it was great. And session 3, he's going to be building up on session 1 and 2. So scan that QR code right there. Once again, that's completely free. And if you want to watch session 1 and 2, just jump on our YouTube channel and they're both on there. You need to get caught up. So let's jump right into sponsors, and then we're going to jump into our first presentation here. Coopervision is our first diamond sponsor, and Justin Kwan is going to be given a 4-minute video. He unfortunately couldn't be here live, so we are going to be watching a video of him. But we want to thank Coopervision for always being a diamond sponsor for all of our myopia management events. And Justin is going to take it away via video.
Well, happy Sunday to all my fellow OD colleagues out there. Thanks to the ODsonFinance team for allowing us to be a diamond sponsor for today. To Dad, Aaron, Julie, and Chris, wonderful partnership here for a very timely and important topic with myopia management. It's such an important part of what Coopervision does day in and day out. And you might think the standard of care for myopia management is coming, but the World Council of Optometry has already established that last year, April of 2021. And so we're obligated to treat these children with myopia that continues to get worse. The younger they are, the faster they progress. So the time is short, and there's so much good that can be done for a lifetime of healthy vision. And while we all know by now that half of the world will have myopia by the year 2050, that tomorrow is already here today. This is 61,000 pediatric eye exams in Southern California at Kaiser. You can see the teenagers, the high schoolers, are at 59% prevalence, and a quarter of them are -3 or worse. And looking at the 2020 census, kind of estimates 19.5 million children with myopia. So if all 70,000 ODs and OMPs did myopia management, we each have 278 kids to take care of and treat and intervene as early as possible for the best long-term outcomes. So if you haven't reached 300 kids under your care, there's more kids that need comprehensive eye exams and need their myopia diagnosed and treated again at an early enough age. So when do we stop? That's the most common question we get asked. Well, let's try to get these kids through high school, no higher than -3. At that point is where these odds ratios of RDs, glaucoma, cataracts, and myopic maculopathy begin to skyrocket. And, patients with pathologic myopia are on average very young, 48, and we'd hate to see any of them live even a portion, not to mention half of their life, with visual impairment. And 2050 is just not a great place to be for average visual acuity. So the Coopervision leadership many years ago saw this future coming. And so they put together a portfolio of companies leading to a portfolio of products. MySight 1Day for myopia control, and Paragon CRT and IC, great ortho-k products for myopia management. The very pivotal 7-year MySight study not only got us the FDA approval for the first 3 years, but the subsequent years of data and results analysis allowed us to understand how efficacious MySight is, and the external validity is just so strong. What you see is that the purple of MySight is able to slow axial elongation to the rate of an emmetrope, and maybe that's the upper ceiling of efficacy. When you take children who have worn MySight for 6 years, that's a total progression of less than 1 diopter on average. And if you highlight the kids that are untreated in their myopia, the orange line, their eyes are growing 2 to 3 times faster than they should be. And that accelerated eye growth is what potentiates the higher myopia and those higher increased risk later on. And so our job is to get these eyes back on track in their axial growth. To wrap up, MySight underwent a power expansion just a few months ago. So there is now a -650 and a -7. And in this back to school period that ends September 30th, there is a $200 prescription savings cards off an annual supply. Because that can be really helpful for parents that are unable to fully afford the whole year otherwise, to really gear their child up for great success during the school year. So thank you for the time, and we wish you a very enjoyable and beneficial learning experience for today's phenomenal CEQA program. Have a good one.
All right, awesome. Well, thank you, Justin, for that fantastic video. Once again, if you do want to contact Coopervision, Felicia Timmerman is going to be the OD to email. And if you want more info, scan that QR code and it tells you everything you need to know about MySight. But a fantastic program. I know a lot of people in the chat have relayed their experiences and their success with it as well. And for our next sponsor, we have Done For You Marketing, and Trish Olson's going to take over here. They are a fantastic marketing group that can get your message out about myopia management to the masses so that you can start bringing these patients in. All right, so I'm gonna let you take over.
Awesome. I'm just gonna do my due diligence. Last time I didn't know how to do full screen, so thanks, Dad. Hi guys, I'm Trish Olson, Done For You Marketing. We are a professional marketing service that helps out the eye care industry. So excited to be here. Being a part of ODsonFinance has been one of the greatest things that we've been through in the last couple months, just because great people, you guys support each other. Different type of membership groups are hard to find that they really support each other. So thanks for the inclusion. Appreciate it, you guys. So Done For You Marketing started in 2015, really started as the need for ODs and MDs maybe needing help with their marketing. But what happened is in the last couple of years, everyone's saying, I want to market. I don't really want to do it myself. I don't really trust who's doing it out there right now because I don't know if it's working or not. So really Done For You Marketing has really evolved into a program that takes the marketing off the plate of the practice, and we take it on for them, make sure that we're doing the right things, and we're bringing in the people, the patients that really can benefit from the services. Okay, so what makes us a little different than maybe some other marketing services out there within the industry, outside the industry? It's really personalized. And a lot of people do say that they do personalization. We're an ad agency, but what we do is all of our design work, all of our marketing plans are custom to the practice and really about the goals of the practice. So if you're telling me that you want to stand out from the competition, you want to increase capture rate, we're going to design a program that fits your needs, and it's not templated at all. Okay, so your look and feel, your brand, very strategic, like I said, going into your goals of the practice, taking it off your plate, trackable. We do work with both ABB Analyze as well as GPN. And so what we do is track everything that we do. So if it's your website, if it's your Google ads, if it's your direct mail, if it's anything that is driving revenue, we want to be able to share with you your spend versus what we're seeing for results. And then affordable. We are a monthly fee ad agency, no contracts. So that's a little bit different than some. And then really, what are the capabilities? Like I said, we are an ad agency. So for that monthly fee, we do handle digital marketing, social, event marketing. So what's big right now? Trunk shows, big deal. And now as far as myopia management, which we're talking about today, and we'll go into a little bit more about our program, but we're handling all of the marketing when it comes to driving in those patients that you want to see that need to be educated on what myopia management means, as well as brand development, other medical, maybe revenue driving services. We handle all of that. So consider us, you hire us, we become your marketing manager. You have one point of contact, and that person handles all of your marketing for you. This is an example. This is one of our senior marketing managers, Darren. She's been with us for 5 years. She manages all of our marketing managers today. And again, if you were to work with Darren, she would be your main point of contact. She would provide proactive communication. So you don't just sign up with us and then have to follow up with us to say, where is this? We have a project management system that we manage through all of our projects. We'll make sure that you're in the loop of all things that we're working on. Another value prop for us, I feel, is that we do full planning and implementation. So not only do we train you and teach you on things that we need to do, but we actually implement it all for you. And then manage all marketing. So it's not just digital, it's not just traditional marketing, it's not just branding. We become that marketing manager for your practice and handle all of those responsibilities for you. Best practice sharing, like I said, we do track everything. And so we can tell you based on your needs, if it is increasing capture rate, is it creating a myopia management program, we're going to share what we've done, what's worked, and then get you a nice starting point. And then the best part, I think, that people get excited about is full vendor management. So if you're working with a sponsorship, maybe for Little League, or you're working with a radio station or TV station or whoever, Yelp, we handle those conversations for you so you don't have to. So obviously we're talking about myopia management today. And so we created a myopia management program, and we have been working within myopia management for the last year and a half. And so we've created collateral, we've created, like processes and systems and forms and everything you can think of. And so the need is now that people are like, okay, let's do this myopia management thing. That's why this is such an important webinar. But how do we implement it? How do we get the word out? How do we brand things? And what's that process look like? So we created a program to go along with that. And Julie had a great idea. My last webinar I didn't really give good examples of visuals. And so I wanted to give you some examples of what we've done now with clients. We have over 250 clients that we work with. So we work with them on folders, brochures, consent forms. These are some examples here. And like I said, everything's custom. So that's why you do see some blacked out information, because these are things that we've developed for individual practices. Packages and pricing. This is actually the most common thing that we work on. It's like, how do we present it to a patient? What do the packages look like based on the different offerings that we have? And so these are all customized. Current patient communications. So for example, eBlast, we do work within all the recall systems. And so we will send out and create communications that go out to your current patients, inactive patients. If it's doctor to optician handoff cards, if it's ways to educate your patients in-house, we create all of those documentations for you, print it, all of that for you. And then of course, anything that's digital, we will design and make sure we get it out to your patients. Website and social media marketing, we handle it all. So from website creation to adding a specific content and design work, we do all of that. We work with the website, we get it all done for you. And then think about any type of Facebook marketing. We do the tiles, the Facebook ads, everything to go along with it, as well as the tracking. And then digital marketing, Google ads, and I'm not sure how many people are marketing it right now, but like I said, we pull all of the analytics, and utilizing the correct search terms in our Google ads and our Facebook ads has been wonderful, because we can track it back to how many people have come in, how many people have called for this service. And so huge deal. So if you haven't done Google ads, definitely recommend it. And of course, we would love to help you with it. So looking at some examples, letting you know kind of what we can do. I know you guys don't have a lot of time on your, time every day to do these things. So ready to drive revenue. We are ready to take it on for you, but also think about these ideas to start implementing, especially to create that successful myopia management program. Being an ODsonFinance member, we do have a special promo until September 30th. If you do sign on with us, you do get $500 in done for you dollars that can be used for Google ads, can be used for brochures. It could be anything that is print, digital, anything that you need to start the process. And then I'll leave with this. We do offer a complimentary marketing assessment. And I know I've seen a couple people pop up here that have taken advantage of that. And honestly, I want to give you some great insight on what we're seeing from a holistic for the practice perspective, but also we can go into myopia management and how we can kind of start that process with you. So if you would like, you can go to our website, you can call me, you can email me, any which way, and we'll get you signed up for a free marketing assessment, no obligation. And then if you do sign up, you do get that $500 marketing or done for you dollars to utilize. And that's it.
All right.
Thank you so much, you guys. I appreciate it.
Well,
Trish,
thank
that
you
was
very
great,
much,
Trish.
Trish. That was fantastic. And once again, I'm going to pull up the QR code here. So scan that if you are interested in getting your marketing material done by Done For You. So thank you again.
Thank you.
All right. And then our last sponsor before we hear from our CE speakers is Precision Technology Services. And we're happy to introduce them. This is the first time they sponsored with us, and they provide instrumentation such as the Medmont topographer. So I'm going to let Natasha from PTS take over.
Awesome. Give me just 1 second to get this rocking and rolling. There we go. All right. Can you guys see my screen okay?
Yep.
Yep.
Perfect. All right. Thank you guys. My name is Natasha Heaviside. I'm joining you from Precision Technology Services. We are the North American distributor for Medmont International. So first off, thank you to ODsonFinance for the chance to say a few words. We're really excited to be a sponsor this year. And thank you for hosting such a great workshop and webinar as well. We're happy to provide a promotion for this event, and you're welcome to reach out to our PTS Medmont sales team. The contact is listed there, and then again, was listed on the previous slide as well. So in 1998, Medmont International released the E300 corneal topographer. It very quickly became known as the standard for fitting specialty lenses and for accuracy. As a GP manufacturing facility, Precision knew that having the best tools in each of our practitioners' clinics would just make their success in ortho-k fitting and in specialty lens fitting that much greater. So we actually became the distributor for Medmont in 2001. For over 20 years, Medmont has been building a legacy that we have been super proud to support, and really excited to share the Medmont Meridia Pro Advanced Corneal Topographer now. So this new instrument builds on the reliability of the large capture limbus to limbus coverage of the E300 corneal topographer, with the added benefits now of high resolution imaging with white light, infrared for meibography and pupillometry, as well as cobalt blue imaging for sodium fluorescein captures. Both video and photo captures are possible. So all of these features just give the potential for improved efficiency in contact lens fitting from ortho-k to regular corneal GP and scleral lenses as well. When you are ready to add ortho-k fitting to your myopia management clinic, PTS is here to help you guys to learn to use your Medmont Meridia Pro to its fullest potential. Our sales and support team at Precision are all experts at topography, as well as ortho-k and specialty lenses. So we're here to schedule one-on-one virtual training with you and your staff. We think it's really important for everybody on your team to be set up for success and to be able to take high quality captures from topography and video and imaging as well. We have built a robust video library for anytime access once you go beyond the one-on-one training, so that you're able to get that training walk through whenever you need it and check in with it, time and time again whenever needed. Going beyond that, every GP lab across the US has access to Medmont Studio. So you have the option to do a really quick topography export and send it directly to your lab, which means you can choose to design contact lenses yourself, or you can also choose to share that information with your lab and work with them to create the best lens for your patient and whatever their needs are. So Medmont Studio does integrate with world-renowned design platforms from Ortho Tools, Wave, CRT, iSpace, Moon Lens, and Emerald Lens. So there are lots of options for you to choose what lens design to use. You can have confidence in knowing that the Medmont Meridia topography will get you on the right path. And then going beyond ortho-k and myopia management, there are many ways to increase your return on investment with your Medmont Meridia Pro. With the incredible imaging capabilities, you also have the opportunity to build and bill for dry eye evaluations. There's secondary return on investment from treatment products and great potential for gaining patient referrals with the impressive dry eye reports that you can share as well. There are so many ways to use your Meridia Pro, from improved consultation support by sharing contact lens imaging, accurate displaced optics on soft lenses or GP multifocals, just by taking a quick topography over the lens. It's really so much more than just an ortho-k tool, and we're excited for you guys to get the chance to try it and see for yourself. So thank you so much for your time, and please reach out if you have any questions.
All right, awesome. Thank you, Natasha. And once again, go ahead and scan that QR code and you can get in contact with Precision Technology Services so you can get your Medmont in your practice. Okay, it's time to jump into our first CE hour. want to put this quick announcement up here. I've had a lot of people email or admin email asking for their CE certificates from past events. So let's go through these 3 steps to ensure that you get your CE certificate when it's sent out. First of all, add our admin account to your contacts. That's important. If you don't do that, sometimes your email will block our email. The reason being is we do use a mass send out. So sometimes your email server doesn't like it. So make sure to add us to your contacts. Make sure you're subscribed to our newsletter as well. Once again, your email may block if you're not subscribed. And even if you do those first 2 things, always check your spam and promotions box because they could end up there. So do those 3 things. That'll ensure that you get your CE certificate from us. I mean, I love responding to emails, but it's great if we can just get it all done in one go. All right, so our first hour of Cooperproof CE is about to commence. So remember, if there are any live poll questions, make sure to answer those. There's a survey after the whole 3 hours. Make sure to fill that out. It really helps us gauge how our speakers did and how we can make these events better for you. You must be present during the entirety of each hour to receive CE credit, and for each Cooperproof CE hour, it's a 50-minute hour, technically. And CE certificates are going to be sent out in 3 to 4 weeks after this event. All right, so our first speaker is Dr. P.Levine. He graduated from the University of Massachusetts at Amherst in 1992 and earned his doctorate with honors from the New England College of Optometry in 1997. He completed a 1-year residency in primary care optometry at the South Boston Community Health Center. He co-founded Vision Care Specialists in Southborough, Massachusetts in 2004. In addition to primary eye care for patients of all ages, Dr. Levine specializes in ortho-k and specialty contact lenses. He's a certified wave designer as well. So, Paul, I'm going to let you take it over.
Okay, just share my screen, or you got it already?
Not yet.
All right. Okay.
You good?
All right, good. All right, thanks. Thanks for joining us, everybody, and thanks to the ODs on Facebook ODs on Finance for partnering up with the AAOMC so we can, continue to give this wonderful information and great learning experience to you all. And at the end of the conversation, we'll talk a little bit about our upcoming conference, Vision by Design. So I'd like to just jump right into here because I have a lot of stuff to get through, and I'll do my best to get through it all. It's hard to, I find it difficult to make these presentations because everybody's coming at this from a different level of proficiency when it comes to fitting ortho-k lenses. Some doctors have never fit one, some have fit many, and so I apologize if I'm speaking a little advanced for some and maybe a little basic for others, but we're going to do our best to kind of keep it where we need to be, and then we'll take some questions at the end. I have nothing to disclose here. And we're going to talk about how to troubleshoot, how we're going to fit the lenses, but how we're going to troubleshoot the lenses. And we're going to talk about some of the problems that we may get into. I'll just real briefly go over corneal topography because as much as I hope this is not the case, I think some people might still be thinking that they can fit ortho-k lenses without a topographer, but it's really not true. Because I suppose theoretically you could fit a lens, but you're going to really struggle in the troubleshooting aspect of it. And you really just have no idea what's going on to the cornea without a topographer. So you really must have to have it. I believe so. And fluorescein patterns are really helpful, but they don't tell you the whole story. And as we all know, the topography measures much more of the corneal shape than we get on an autorefractor or a keratometer, which gives us only about 3 millimeters of the cornea. And I think the big thing to remember when it comes to fluorescein patterns is that if you have less than 20 microns of tear layer underneath that lens, you're not going to see it. It's just going to look black. It will not fluoresce. And that's a really important thing to consider. So when you look at the fluorescein pattern of a lens, when you see dark, it doesn't necessarily mean touch. The problem is it might mean touch, and touch is generally a bad thing. We always want at least 5 microns or so of tear layer between lens and cornea. When you look at the central 3 millimeters of a cornea, you get that much information. But when you expand that out to your full topography, you can see that this cornea is anything but normal. And so you really just have to have a topographer. It's not only going to help you fit and troubleshoot, but it's going to help you decide who is and who is not a candidate for ortho-k. So the first thing you really need to do when you're fitting a lens is make sure you get good topographies, right? This is an example of a really good topography. I trust the data on this. This is an example of a not so good topography. As you can see, the Myers are breaking up centrally. And it gives you a funky looking topography. This is also a bad topography because there's so much shadowing that we're really losing a lot of information, especially inferiorly on this one. So the Ks may be good, but your periphery is kind of lost in this. So once we have decided that, okay, we got a good topography, now what is it that we're actually trying to accomplish when it comes to fitting a lens? I mean, we have to consider that there are a lot of hydraulic forces underneath those lenses. There are forces that push down and there are forces that lift up. Both are just as important as the other. It's just as important to create that high red ring as it is to create that flattened central blue zone. And so ultimately, this is what we're hoping to accomplish. We would get a nice looking fluorescein pattern, which would then give us a nice looking topography pattern. So that's really the goal. So when it comes down to troubleshooting, there's a bunch of different ways you can go about this. I mean, you can think about it, you can mull it over. I find that having colleagues that you might be able to share a case with and say, hey, you know what, this one's just not going the way I think it should go. What do you think about this design? What do you think about these lenses? What do you think about this fluorescein? What do you think about the topography? And that can be really helpful. And your lab consultants are instrumental as well, where you can share your topographies and you can share videos of your fluoresceins, and they can really help you get through that project. And sometimes, and you'll find this if you go to Vision by Design, you may get the most education sitting at the bar at night after the formal lectures have actually completed. So sometimes a little mind opening, substances can help. So I want to just run back to the retinoscope. The retinoscope is really important when it comes to doing ortho-k because not only, well, autorefractors just simply don't work when you're dealing with a molded cornea. And anybody who's done any number of these cases knows that to be the case. So you really have to use your retinoscope to know what kind of residual refraction you're dealing with. And also it helps you identify the treatment zone. You're going to see this on the next slide. So this is a video that I took. This is, I literally taped my retinoscope to my phone, to the lens on the camera lens on my phone, and I scoped this patient's eye. Unfortunately, she had a nice big pupil, and you can very clearly see that treatment zone right in the center of that pupil. And I find that that's really important when it comes to assessing your the quality of your fit. And if you look at this, this is the topography of that person. You can really see how well centered that treatment zone is, and you can see how well it translates into the topography. So I'm going to go through this really fast because I think you guys all know this, but the treatment zone, sometimes referred to as the base curve, is the very center of this lens. The reverse curve is where that lens, as you can see, lifts away from the cornea and gives you some clearance right there. The alignment curve is where that lens comes back and lands on the cornea, as you can see right here. And then you have your peripheral curve, which is where you get a little bit of edge lift. And we always want a little bit of edge lift. We don't want that thing diving down too deep into the cornea. We want to see that nice little strip of fluorescein. So let's get into the troubleshooting. I will talk briefly about, in my opinion, I think troubleshooting starts before you even fit a lens. Troubleshooting, and I'm going to show you this a little bit greater detail in a couple of minutes, but you have to know the cornea that you're dealing with. You have to be comfortable with the lenses that you're using. And you have to anticipate where the problems might arise. So this is a situation where we call this a smiley face pattern. This is the typical pattern on a malfitted lens. And I want to really talk about the nomenclature that we should be using. As when we learn how to fit contact lenses, we learn phrases like it's a flat fit, it's a steep fit. But when it comes to reverse geometry lenses, and when it comes to ortho-k, those phrases can mean a lot of different things. Is a flat lens, if it's too flat, does that mean that it's not fitting the cornea properly? The cornea is steeper than the lens? Or does it mean that the base curve was calculated wrong? It's too flat, it's overcorrecting the eye. We really have to stop using the terms flat and steep. I find it much more useful to use the term for a flat lens, an insufficient sagittal depth. So I'm trying to match the sag of a cornea with the sag of a lens. If my lens is not fitting properly, it means that I have missed that. And so when we talk about a flat fitting lens, we really want to talk about a lens that has insufficient sagittal depth. And when you have a lens like that, it's typically going to ride high. The lid kind of pulls that lens up. And you'll get this kind of smiley face topography pattern as that lens is riding up high. And so this is just kind of a little schematic way of understanding what it is that we're looking at in that photo. And so you can see that basically we're crashing into the central cornea. And as I had mentioned earlier, we really want to have a little bit of fluid between that lens and that cornea. And in this case, we do not. And so on a fluorescein pattern, it's going to look pretty dark, but we, again, can't really tell in that fluorescein if it's crashing into the central cornea or if it's just clearing it. But when the pattern of the topography, when the pattern of the fluorescein rises up and you can see that what we're doing is we're losing our alignment zone here because this lens, the sag is insufficient, right? And so it's crashing into the center of the cornea, which is causing it to lift off in the alignment area. And that's giving us a little bit of flooding down in here. And so when we talk about like the CRT lens, which is a really popular lens, and most people know the terminology with a CRT lens. So in this case, with an insufficient sagittal height in CRT language, that might mean the return zone depth is not quite appropriate. It's insufficient. And so as you can see here, we're losing our alignment zone. And when the landing zone angle, this is again a CRT thing, is flaring up like this, and you're getting this excessive pooling. If you think about it, if this is too high, then it's dropping the center of the lens. If we could push this down a little bit, it's going to push the center of the lens up a little bit, and it's going to be another way of increasing the sagittal height of that lens. And so how do we fix it? Well, we increase the sagittal height of the lens. How do you do that? You could do that by steepening the alignment curve. You could do that by increasing the return zone depth. You could watch the edge lift. And again, if there's too much edge lift, you want to decrease that. You want to tighten that up so that'll pop the lens up a little bit. You also have to beware of lids because eyelids can really make trouble. When you look at fluorescein patterns with somebody that's sitting upright in your slit lamp, you can't really tell what that lens is going to do when the eye is closed. And that's another reason why the topography is so important, because your first clue that a lens is decentering while asleep is the topography after they sleep in it. So sometimes if you can't get a lens to stop riding high, you can put some base down prism into it. Not all lens designs will allow you to do that. Sometimes just making the lens a little bit thicker will help drop it because it literally becomes heavier. If you're custom designing lenses, if you're using design software platforms like Wave or iSpace or OrthoTool, then you can set those thicknesses that you want. If you're using a CRT lens, for instance, you can ask for an enhanced thickness lens. You can do the same with some of the other lenses out there that usually you have to talk to the consultants to get that done. Increasing the overall lens diameter is another way of improving centration. And the toric periphery. So when you have a cornea that is not spherical in the periphery, you're going to have a hard time getting that lens to stabilize because you're not going to be able to lock down 360 degrees, the alignment area. So I want to talk about a really important, in my mind, when it comes to designing ortho-k lenses, the literally most important topography that there is, and it's the elevation map. Those three topographies that you're looking at right now are the exact same capture expressed in three different ways. Your axial map, it describes the power of the cornea. Your tangential map kind of describes the shape of the cornea, but your elevation map explains to you how much that cornea differs from a sphere. That's really important because if you think about it, a non-toric ortho-k lens, and when I say that, I'm not talking about the power of the lens. I'm not talking about the base curve of the lens. I'm talking about the alignment curve of the lens. These lenses get fit from the outside in. That's how you have to think about this. If you can't get the alignment curve right, you're not going to get a good result. And so if you look at that elevation map, you can see very clearly that at superior and inferior, you have a steeper drop, if you will, than you do along the horizontal meridian. There's no way that you can get a spherical alignment curve to align on a cornea that looks like that. So if you understand that, then you're going to get a good result. And if you look at especially, I want you to notice the red ring on that lower topography, you'll see that the red is much deeper and darker in the superior and inferior, because in order to get from the center of that lens to the periphery, you have to drop it down further. In other words, the reverse curve is going to be higher in the steep meridian than it is in the flat meridian. So let's look at another example. Again, this is the exact same capture expressed three different ways. And I'm going to just ask the question, when you look at that axial map or you look at that tangential map, would you ever expect the elevation to be that asymmetrical? Because I think the answer should most likely for most people on this call be no, I wouldn't have expected that. And so when you have a cornea that looks like that, where do you think that lens is going to end up? Because I can tell you that just by looking at this, you know that that lens is going to drop. It's going to fall into that little gully of a blue arc down at the bottom of that elevation map. And indeed, this is what happens. And not only does and this is relatively centered, actually. It's not that decentered, but it really kind of is. And if you look at the treatment zone, you'll notice that we've got more deeper treatment here and not as much here because that lens is tipping. It's tipping downward. And so we're getting a little bit more compression down here and a little bit less up here, right? Because the lens is kind of almost wanting to sort of drop off the eye. So we're going to dig a little bit deeper into elevations in just a few minutes. This is what we call a frowny face topography pattern. This is when a lens falls. This is when it drops down. And this is when I, again, discourage the term steep fit. I want you to think of this more as too much sagittal height. And typically these lenses will drop down and you'll get this kind of frown looking face right here, this kind of sad looking topography. And again, this is that sort of same graph that I showed you before. So when the lens has too much sagittal height, you really don't make it to the cornea as much as you might want to. And you kind of overdo it down here because this angle is too steep. So you're crashing into the cornea. You can see how dark that is here. And oftentimes you're going to get a bubble in that reverse curve, as you can see in this picture here. So this is a decentered down, very small treatment zone, excessive sagittal height lens. And so again, if we, kind of translate that into the CRT language, there's too much depth in the return zone, or there's too much angle in this landing zone. So it's kind of digging in too much and it's popping that lens up. And you can see in this picture here, there's almost no discernible treatment zone because this is just way too, like, we're smashing into the cornea here and it's not allowing the center of that lens to drop into position. And so the way you fix that is you flatten that alignment zone, alignment curve. You make it less steep, or you decrease the landing zone angle so that, again, you can kind of drop that lens down. You know, every change on a CRT lens, any change in the return zone is in 25 micron increments. In the landing zone, because that is expressed in degrees, any change of 1 degree equals about 7 microns change in sagittal height of the lens. Again, other things we could do, maybe we could thin that lens a little bit so it's not as heavy, but we have to be careful that we don't create a lens that's so thin that it flexes on the eye. And back to toric, we need to make sure that we don't need a toric periphery. And again, we can look at the overall diameter of the lens. The trouble with doing this kind of work is that it takes experience to know what you're looking at, because sometimes a lens can ride high or low, and it can be because it's either too steep or excessive sagittal height or insufficient sagittal height. Like sometimes both things can happen and cause a similar look. So you really have to look at the topography and see that you're out of position, and then use your fluorescein pattern to help guide those decisions. As I said before, if you can't really identify a good treatment zone, the lens is too high, you know, too tall, depth is too great. If the lenses are flaring out or the treatment zone's really dark, you know that that lens is insufficient in a sagittal depth. And if you have central SPK, it typically means that you're rubbing the center of the cornea. I didn't do this as a poll. I just want you to ask yourself this question. If a lens drops, which is the most likely answer as to why that would be? All right. So a lens that decenters inferiorly means we have underestimated the height, or we have overestimated the height, or the base curve is too flat, or the base curve is too steep. I'll give you just a second to think about that. But as we learned before, typically, if a lens drops, it's because it has excessive sagittal height. So number 2 is the answer. However, if anybody on this call chose 3 or 4, you need to understand something really. This is maybe the most important thing I'm going to say today. The base curve is never, ever, 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 ever used to control the fit of an ortho-k lens. Okay, I'm going to say that again. The base curve is not the thing you adjust to fix a poorly positioned lens on the eye. The only thing the base curve does is adjust for the power of the lens, the target power of the lens. If the base curve is too flat, you're going to over-treat the myopia. If the base curve is too steep, you're going to under-treat the myopia. We've always learned that if a lens isn't fitting right, you adjust the base curve. Well, it doesn't exist in ortho-k. So let's talk about toric alignment curves. Again, I'm not talking about power, I'm talking about fit. This is a toric cornea, as you can all pretty clearly see. So let's go back to the elevation map. These are, you know me, I love these elevation maps. It's how I live and die. If you look at those numbers, what I did was I looked at the chord length of 8 millimeters, so 4 millimeters from center, top, bottom, left, and right. And I calculated how much under or over the best fit sphere on this cornea we were dealing with. And as you can see, in the superior meridian, we're 30 to 40 microns below a sphere. And in comparison, when you look at the horizontal meridians, we're flatter than that sphere. So if you just very simply think about how am I going to get an alignment curve to align, you can see clearly with this map that there's no way you're going to get a spherical alignment zone. You're either going to way crush the horizontal meridian, or you're going to lose the superior meridian. Now, this is just another way of kind of looking at that. This is this map that you see right here. I'm about to show you what that looks like in a in a software design. So what you're looking at here, I seem to have somehow lost my laser pointer. There we go. So so this is what we call a tier layer profile. Okay. And this is what we would look at as the fluorescein pattern of this lens here. And so what we're looking, and then this is the lens and this is the cornea. So this line right here is the cornea. This line right here, just so you know, is the 20 micron line. Why do we have a 20 micron line? Because you can't see any fluorescein if under this. So it's black, it's green, it's black, it's green, it's black, right? So this right here is aligning nicely with the cornea. This right here is above the cornea. This right here is approaching the cornea, and et cetera, et cetera. This is the flat meridian of this. But what do you think is going to happen in the steep meridian if I use the same curvature that I have here and here? It's going to look like that. And so what you can see here is that we're nowhere near getting down onto the cornea. And look at right in here, you can see that that lens is missing. It's not able to get to the cornea in this steep meridian. Okay, because this is just, this curve is too flat. This curve needs to be steepened. It's harder to get from here to here in the steep meridian because it drops down quite a bit, just as we saw in this map. We're losing it. We can't get there. So that's why we need to put a toric alignment curve on this lens. So let's go into some other things that we talk about. And guys, if you could kind of let me know when I have like 5 minutes left, that would be great. Because I don't really remember what time we started. So this is called a central island. A central island is something that you might encounter from time to time. And you'll notice this is what we call a difference display. So this is the baseline. This is the post-fit lens, post-fit topography. And this is the difference between the two. And we can see, if you look at this number, plus 0.59. So what that means is right where this arrow is pointing, right here, we've actually steepened the cornea by 0.59 diopters. Okay, that's not what you want to do when you're treating myopia. If you were trying to correct hyperopia with ortho-k, this would be a wonderful outcome. But we're not. We're trying to make a myopic treatment. And so you can see that we're getting some flattening here, but we're actually steepening up the center of the cornea. And that happens when you're excessively high in the sagittal height. And you'll actually have induced more myopia. So when that lens is too steep, basically it's sucking the tissue up into the treatment zone as opposed to compressing down in the treatment zone. So why would this happen? Well, maybe you had bad topography. Maybe your K values were wrong. Maybe you ordered a lens incorrectly and one of your parameters got screwed up. Maybe the patient put the wrong lens in the wrong eye. I mean, nowadays we can control the color of the lenses, so that rarely happens. If you have a radioscope in your practice, you can throw that lens on and make sure that the base curve you ordered is what you got. I had one situation where kids' lenses came in and I had just that exact thing happen. And I put the lens on the radioscope and literally the lab sent me the wrong lens. But it's really hard to know that unless you can verify that lens. There's this other thing called a fake central island. And as you can see here, we're creating a nice myopic treatment zone, but we got this little bump in the center right there. Okay, this would actually be a really nice multifocal molding, but that was not the intention here. And so what's happening here is we're creating this little hot spot in the center. And that is going to happen for just the opposite reason of the true central island. This lens has insufficient sagittal height. and it's rubbing the central cornea. And when you rub the central cornea, you disrupt the epithelium, and the topographer doesn't typically know how to deal with that. And so it expresses it as a high spot. Remember before we told you that on a central island, you're going to have induced more myopia. In this case, we're still going to have decreased the myopia, but we're going to have that little nipple right in the center of it. And you're typically going to see distorted Myers on your topography, and you're typically going to see some central SPK. You need to make sure that your lens, you need to reassess the fit of the lens and look at the lens and make sure that it's not coated in protein, that it's got a bunch of scratches on the inner surface. Inspect the lens. And if that lens has a ton of protein buildup on it, use your ProGent to remove that protein. And sometimes if you've only had a lens on if this is your 1 day follow-up or even your 1 week follow-up and you see something like that, sometimes you just have to give it a little bit more time for the treatment to come fully effective. So sometimes you just have to be patient and not make hasty changes. So here's another question, not really a poll question, but I just want you to think about it. And so we just talked about this. What's the difference between a central island and a fake central island? So we know that the fake central island does not show corneal steepening. The true central island does. So that's false. The fake central island shows steepening in the center of the treatment zone, but the steep area is still flatter than baseline. So we know that that's true. We know that 3 is also true. And we know that 4 is probably not true because in 4, we've induced myopia. So there's very little chance that that lens is actually rubbing the central cornea. Lateral decentration is the hardest thing to fix because sometimes it's really hard to identify why a lens decenters laterally. Looking at the topography, looking at the fluorescein, and making some decisions there. Typically, the diameter of the lens is too small when you have lateral decentration. Sometimes you're dealing with a decentered corneal cap and there's nothing you can do about the decentration. And sometimes you have to live with it. But if you make a smallish treatment zone, you can still manage to keep that within the pupil borders. So sometimes you have to live with a little bit of lateral decentration. But typically, it's because the lens is too small. And so you always want your lens to be somewhere around 95% of the horizontal visible iris diameter. Now, not every topography will allow you to examine the horizontal visible iris diameter. Sometimes you have to go to the diagonal visible iris diameter. You're probably not going to get the vertical because, again, most topographers cut off the top and the bottom. This is just what it looks like when you measure the HVID. So you can see here that horizontally, this thing measures about 11.8 and diagonally about 11.9 or 12. So typically the cornea is a little bit larger in that diagonal. And sometimes it's hard to know exactly where the limbus is. So generally overestimate. Better to have a lens that's a drop too big than a little too small, in my experience. Another cause for decentration is if that lens is rubbing the central cornea because you've got insufficient sag. Sometimes, if you've got too much sag, it's going to decenter because it's dropping a little bit too much. So again, this sort of goes back to you have to be you've got to be a detective and you have to look at everything, your topography, your refraction, the position of the treatment zone, and the fluorescein patterns. Sometimes the tight eyelid thing can really push a lens around. Sometimes people sleep on their face or they sleep on one side and it can cause some changes. Sometimes you have to counsel patients on literally the position that they sleep in. Some patients have lagophthalmos. If those lids split apart a little bit at night, sometimes that's going to cause SPK or it could cause some slight decentration of the lens. Sometimes you have to manage which lubricating drops you put into the lens before the lens goes on the eye. Maybe you had bad data that you started with. Maybe your baseline data was off. Recheck those topographies. And sometimes, like I said, they just decenter no matter what you try. And once you get really good at ortho-k, some of us will start getting into some larger designs where we're actually bigger than the HVID, where you might fit a lens that's 13 or 13.5 millimeters or even larger. Either corneal scleral or literally scleral ortho-k designs. We're not going to get into that today. It's a little bit beyond the scope of what I think this talk should be. And make sure your lenses are clean. Thank you. Make sure your lenses are clean. Make sure that back surface, that the ocular surface of the lens is clean. Because if it's covered in protein, it's just not going to fit right. I mean, we're talking about 5 to 10 microns of difference can make all the difference in the world with an ortho-k lens. And I don't know how thick a protein film is, but it's probably at least a few microns thick. And it's going to start wreaking havoc on your fits. And don't be your patient's best buddy and let them wear their lenses for 3 years because you want to save them a couple of bucks. Those lenses need to be replaced annually. They start to warp, they start to scratch, they lose the surface quality, even if the treatment doesn't need to be changed, even if the myopia is stable. So I want to leave a few minutes for questions, so I'm not going to really go into this, but when I'm designing lenses, if I have a 12 millimeter cornea, I'm going with an 11.4 diameter at about 95%. None of these are really wrong, except that I think one is probably the one that's going to give you the least success. Okay, so let's go back to troubleshooting again, and let's go back to decentration. Is this a decentered map? And I'm going to tell you that it is, but not that much. In fact, it's really only decentered by about 0.5 millimeter. But it looks quite decentered because look at how much of this blue extends to the limbus, but on this side it does not, right? And so it's like the whole thing is offset to the left, which makes the treatment zone look like it's offset to the right. And one of the ways that you can deal with that is by literally moving the patient's fixation. So again, you'll notice all the blue over here, but not over here. This thing looks like it's shifted left. Well, by simply moving the patient's position of gaze, you can see now that we sort of equalize the blue on either side of the treatment zone, and you can see that it's well centered within this pupil, and it no longer looks decentered. I took this one, then the other. These were done right after one another. And the way I did that was, I said, hey, and I literally have a printout of this at my topographer. I said, don't look here. I want you to look here. I want you to count 1, 2, 3 rings over. And once you do that, then again, you can center that thing much better. So when somebody has an angle kappa that's off, when somebody's, literally line of sight is not the same as the line of sight of the topographer, you're going to get that. This was a fun little case. This was a 1-day follow-up on a lens that looked really good at the time I dispensed it. And this was because the lens bound to the eye. So this patient wore their lens into my office. It's kind of controversial. A lot of doctors like to do it. I do not. I think it gives the opportunity for that lens to kind of get stuck in a bad position. Doctors sometimes like to see the position of the lens, so they have the patient wear the lens into the office. But in my experience, I think it's a bad idea. If you do have a bound lens, tell your patient that this could happen. The best thing to do, put a couple of eye drops in, and kind of almost like the way you would loosen up a scleral lens, you have them look up, kind of push on the globe a little bit just below the edge of the lens to try to kind of like dent the eye, so a little air bubble kind of shoots up under the lens and it'll help push it off the eye. I'm not going to go through this because you all know what corneal staining is. A little bit of corneal staining is probably okay. A lot is probably not okay. Corneal staining either because the lens is dirty or the sag is insufficient. So that's corneal staining. We don't really have to go through that. Sometimes surface quality of the lens can look crappy like this. Sometimes ProGent can help that. Inspect your lenses, make sure they're not chipped, cracked, broken. This is called dimple veiling. This is not SPK. This is when an air bubble gets underneath that lens and breaks up into a million little air bubbles and causes little compression dents in the cornea. And they'll fill up with fluorescein. The retinoscopy reflex will be really dark and the vision will be kind of funky. It'll get better on its own. It just takes a little time. If they're not using the proper viscosity drop inside that lens when they put it on, you might get this. We see it from time to time. You'll notice right here, this little iron ring, nothing to worry about. It happens in the area of the reverse curve, typically in highly nearsighted corrections. Nobody has been able to identify this as a problem. Again, I'm not going to dig into microbial keratitis. You all know that it's really bad. Just make sure your patients are compliant with their cleaning regimen and quiz them on it. Again, walk me through how you clean and disinfect your lenses. I want to know. Tell me exactly what you do. And they'll say, oh, I take the lens and I rub it. And I'm like, oh, did you wash your hands first? Oh, yeah. So make sure you go through that process with these people every time, because they start to get a little cavalier the longer they're in the lenses. The biggest study to date on this Ohio State study showed that the incidence of microbial keratitis was 7.7 cases per 10,000 years of wearing ortho-k lenses. So it's a small but not insignificant thing to think about. Loss of effect means, hey, it starts off great, but now suddenly they're starting to show a little bit more of their myopia. The axial length is still stable. This can sometimes happen if the lenses are in the wrong eye, if the lenses are warped, or if you got a sibling set and they somehow got each other's lenses in each other's eyes, which I've seen a bunch of times. Usually if I have siblings, I put one in a red-yellow lens configuration and one in a blue-green configuration. If there's a lot of complaint of glare, you can try to increase your treatment zone diameter. Some doctors are using alpha-GAN off-label to create a little bit of pupillary meiosis at night. And sometimes you can apply aspheric treatment zones. Again, that's kind of in your software designs. We already went through this. So I want to go through just a couple of cases really quick. Does anybody think that's a good fit? Because it looks kind of superior and it looks kind of like it's flaring on the lower, right? But it was a good fit. And this was the topography that I got out of it. And I want you to watch this video because this will kind of explain, if I can get it to play. Hold on, I got to shut off my laser pointer, I think. Here we go. So watch what happens to this lens when we remove the eyelid from the plan. Once you get that eyelid off, that thing centers really nicely. So it looks decentered because the lid is pulling it up. And that's why you really don't know what these things are going to look like until after they've slept in it. And you'll see, and every time I do this, I always pull the lids off because it gives me sort of my best understanding of what the lens might fit like when the force of that lid is not pushing down upon it. So this looks like not a great fit because you can see that bubble in the return zone. You can see that the treatment zone is a little shallow. And indeed, it turned out crappy. And what I did was I kind of loosened up that alignment curve. This is the way these maps used to be displayed before they gave us the whole cornea. We only saw half the cornea. And so what you can see that the alignment zone was down here and I lifted that up, which decreased the sag of the lens. Got me a better treatment zone. I'm sorry, I don't have an after on that one. Again, I'm going a little fast through these. This is another one that looks like it's excessively high on the sag because we have kind of a lousy looking treatment zone. We have a really fat return zone and we have a bubble in that return zone. So this one actually turned out okay because it was a -7. And sometimes in those high minuses, you do get kind of a fat looking treatment zone. And sometimes if they're tearing a lot, the fluorescein will look kind of floody. But I did adjust this lens. And what I did here was I basically decreased the curvature in the alignment zone. So in other words, I kind of loosened up the alignment area, which dropped the center of that lens down just a little bit. And this is what that next lens looked like. You can see that I have the return zone does not look as fat. Still got a couple of little bubbles in there. Again, with high myopes, sometimes you get that. But I got a bigger, wider treatment zone. And you can see the difference in these displays. So this one here was the first lens. This one here was the second lens. Just a couple of pearls. Especially if you're new at this, the first patient that tells you, I want to do ortho-k is probably not going to be a good candidate. Make sure they're a good candidate. Make sure they're not a -6 with 3 diopters a cylinder. You know, you want to build success early in your ortho-k practice. Give as much information as you can, make yourself available. Do your own topographies. It's okay to have a staff member do your topographies post-fit, but when that baseline topography is the most important topography you will take. And if anybody is to blame for a bad topography, it should be you. And don't make hasty changes. Give the lenses a little chance to really do their thing. At least a week. Never make a change before a week unless it's a total disaster fit. Rely on those topographies big time, and make sure your staff is really invested in this. And do more continuing education. You know, this 1-hour lecture is not nearly enough. If you want to learn more, I invite you to come to Bellevue, Washington next month. We're going to have our Vision by Design meeting, which we're going to talk about a little bit later, and you'll just get wall-to-wall myopia management, myopia control, and ortho-k. And by the way, you'll get to like sit down at a dinner table or a bar room, chat with some of the world's literally like leading experts in ortho-k. I mean, it's like the best conference ever, in my opinion. I'm the president of the academy, so, but I used to not be. And it was even my favorite conference then. So with that, I'll hand back over for questions if there are any.
Oh, that was awesome. We do have a couple questions.
Okay.
You mentioned some of the problems with ortho-k lenses that are too small. Are there problems with ortho-k devices that are too large?
Yeah. If a lens is too big, sometimes you're going to have a hard time getting a proper treatment zone. And you have to be a little bit careful about where you're landing on the limbus if you put too much pressure on it. So generally speaking, you want to be just a little shy of the limbus. However, if you are going to go rogue and you're going to fit a scleral design, now you're just going way beyond the limbus, but that's, sort of a whole different, I think that's a different animal.
Gotcha. And so another question is, when you're supplying a new lens for a change in the fit, do you tell the patient not to wear the old warp lens for a few days before going to the new pair? Not usually.
It can be challenging. It's a difficult decision. If I'm making a small change or on the fly, I will not do that. Sometimes I might say, hey, I tell you what, don't wear your lens tonight and then start again tomorrow night. But I never usually go more than a day off unless I'm literally washing out the patient and refitting with a completely different design.
Gotcha. And last one here, Paul, do you let patients use ProGen at home?
I have like 2 patients that I do because they dirty up a lens instantly. But for the most part, I don't, and mainly just because it's bleach. I want to be really, really, really in charge of that. I think that, I'm sure it's safe to be used at home, but it's just one thing that I'm not super comfortable with.
Gotcha. Great lecture. As always,
Thank you.
Aaron, want to take it away?
All right, awesome. Yeah, Paul, fantastic lecture. And once again, I know there's a few other questions from that lecture. We will get to those a little later. Just want to keep us on schedule for our CE events. And Vision by Design, once again, scan that QR code right there. Best meeting on myopia management and myopia control out there. So it's happening in about a month. So you still got some time to register for it and check out beautiful Washington while you're at it. And we're gonna hit a quick intermission here, about 10 minutes. So if you want to get up, stretch, use the bathroom. And Anith is actually going to come on and he's going to build on what Paul was talking about. Specifically, he's going to be talking about implementing topography guided custom ortho-k designs. And just a quick bio on Anith, he's the co-owner of Evolutionary Eye Care in Houston, Texas. His clinical emphasis is in anterior segment disease, including keratoconus, specialty contact lenses, ocular surface disease, and myopia control ortho-k. He's the president of the Harris County Optometric Society, Texas leader of Young ODs of America, clinical adjunct professor at the University of Houston College of Optometry, a board member of the AAOMC, and board member of Young OD Connect. He's a fellow of the Squirrel Lens Society and the International Academy of Ortho-keratology and Myopia Control. And I do want to send a special thank you to Nith. If you were at this event or last event, he was the one that curated all these CE speakers for us. So just want to send a thanks to you. And if you want to take it away, Nith.
Great, yeah, thank you, Paul. That was a great lecture. So let me share my screen. We're going to talk a little bit about utilizing topography guided custom ortho-k designs. So share. All right. So if you do want to do those -6, -3s, this is the way to do it. All right, everybody see my screen?
We good?
Good, Aaron?
Yeah, we're good.
Okay, wonderful. Okay. So just to start, gotta say, join the AAOMC. It is the organization to learn all about myopia control, ortho-keratology. It is a group of passionate doctors that are not only so enthusiastic about ortho-k and myopia control, but so enthusiastic about teaching it and sharing it to our colleagues. So highly recommend joining AAOMC. Now with custom guided topography-based ortho-k designs, you are completely in control. You're not leaning on a lab consultant. You're not leaning on an algorithm. You're making all the decisions. So you're in the driver's seat. You get to control every single part of the design. So it's a little scary when you first get started, but it's so rewarding because you know you are making a design that's completely custom to that patient, and you can just target higher levels of myopia, higher levels of astigmatism, and hyperopia as well. So Paul really hit on this earlier in his lecture, but with custom designs, topography, even more so important, I would say, because you're leaning so heavily on it. You're making a design that's based off of this image. So you want to make sure there's no artifacts. You want to get a great image capture. And this is an example of a great one. See the lids and lashes pretty much out of the way. You're imaging the entire cornea. You don't want any artifacts because once you have garbage in, you're going to have garbage out. So you only have one shot at making a great first impression. All right. And topography is no different. You got to have a great image to start off with, because once you have a bad topography that you're making a topography based design off of, troubleshooting is just going to be a mess. So take your time, take multiple images. I do have staff actually do our topography. They're better at it than me nowadays, but they take multiple images. And if I don't get an image that looks like this, I have them repeat and repeat and repeat until they do. And if they don't get a great topography, they just might be a good candidate. So here is one example of a custom topography-based design, Wave, which is a fairly popular one. This is their new software. And what you're seeing on the top is what actually the ortho-k retainer looks like on the cornea. It's not just a cartoon picture that if you change the parameters, that image will change as well. So that shows the thickness of the retainer. It shows its relation to the cornea. And down below is a tear film analysis. So you see right in the center, you have a very thin layer of apical clearance, which is where the base curve is. And then you see this ramping up of tear film, which is where the reverse curve is. And then you see this red and blue dot, which are control points in Wave, where you can control how much sagittal depth you're increasing or decreasing. And then you come down to between the blue and pink dots, which is pretty much where the alignment curve is. Now, you can go around in every single meridian. There's over, I think it's 1,200 or 2,000 data points in Wave, which you can customize. So you're not just making toric decisions. You're not just making quadrant specific decisions. These are every single meridian you can completely customize. So you can go a few microns, just superior temporal, and then change 100 microns inferior nasal if you wanted to. So completely freeform design. They also offer geometrically symmetric and rotationally symmetric, which is akin to spherical and toric design. So this is one of the software that's out there. That's Wave. Another one that's fantastic is called iSpace. This is what their platform looks like. So the top area is their tear film analysis. So it shows a fluorescein image of the vertical meridian and the horizontal meridian. So you can see what it looks like in both. The bottom image is a simulated fluorescein design, fluorescein simulation. That blue picture you see on the edges is where they're anticipating some touch, which you'll want to see kind of that horizontal meridian. It shows a properly fit ortho-k design. And then centrally, it'll actually show the estimated microns of clearance. And Paul mentioned this in his lecture where, if you have 20 microns or so of clearance, you may not notice it under the slit lamp. You need about greater than 20 to 25 microns of clearance for fluorescein to actually glow at the slit lamp. So when you see that black area centrally, you'll know you'll have less than that, but it's not actual bearing. If you're actually getting true bearing centrally, you'll see that central keratitis, which is something we don't want. And in this simulated tear film analysis, you can see while it's low centrally, we're not actually bearing on the cornea. And with iSpace, you can also make all the modifications you want. You can change the back optic zone radius, not only the curvature, but the size of the treatment zone. You can decide whether it's the vertical or the horizontal meridian, how much you want to increase or decrease the sagittal depth at the return zone or the alignment curve, how you want to change the peripheral curves. You can change how much treatment effect you're having, so it's completely customizable. And seeing this tear film analysis in addition to the simulated fluorescein image below really gives you a good idea of what to expect. Again, this all goes for naught if you don't have a great topography to start off with. All of these images, whether it's WAVE or iSpace, is based on the baseline topography that you provide. So that simulation is based on good data to come in. So I can't emphasize enough, make sure you get good baseline topography. And then the last one, Ortho-Tool. This is the one I don't have much experience with, but another one that's popular that does also use a custom topography-based design. But you see that all of these have a similar concept. They're showing the tear film analysis. They're showing you what you can expect to see underneath that ortho-k retainer. You'll have that thin layer of tear film underneath the base curve, then a sudden ramping up into the reverse curve, and then flattening back out towards the cornea and the alignment curve and then another area of edge lift. But what's cool about these is you can customize how much sagittal depth you want under each curve. And with Ortho-Tool specifically, you can change asphericity to also manipulate what kind of tear film layer you're getting. So you don't have to just steepen or flatten certain curves. You can change asphericity to get a little bit extra peripheral plus in the reverse curve, or get a little extra treatment effect. So again, that's a little bit beyond of what I want to go into, but you just need to know that there's so much customization available with all three of these designs. WAVE, iSpace, and Ortho-Tool are probably the three biggest ones in the custom topography-based design area of ortho-k. So once you have those patients kind of coming in that are not your typical -2s or -3s, you're getting the -6 and 2 diopters of SIL, and you got 10 or 15 cases of ortho-k under your belt. These are the designs you really want to start looking into where, again, you're in the driver's seat. You're making the decisions and you can really expand the patient basis of who you can treat. And once you do that, your results are just going to improve. And this is, I believe, over a -7 diopter myo. And it's pretty textbook. And this is consistently what you can get when you're having a custom design that's topography based and you have a good baseline. So we have this beautiful peripheral plus ring on that right image and a beautiful treatment zone, but it all started with getting good baseline topography. So once you start implementing these custom designs, your results will get better, your patient base that you can treat gets better, and overall your patients will be a lot happier, and you yourself will be a lot happier as well. So how do I learn? How do I get started? How do I know where to implement and which patients to use these custom designs? Only one place to go. That's Vision by Design. You will learn all the techniques you need to really start implementing the basics of ortho-k, but then also stepping your game up to getting into the custom designs as well. And as Paul mentioned, so much of that education happens even outside of the classroom as well. So highly recommend attending Vision by Design this year. It's going to be a great time. Open up some questions. That is my direct email. I put my Instagram on there as well, because to be honest, that's probably where I get most of my questions these days. So I do post ortho-k cases and some other cases on my social media. So feel free to email me or message me on either platform. And if there's any questions, I'd be happy to answer.
Great stuff, Anna. So the customized software seems amazing, but for those who may feel intimidated by it, what's the learning curve for for feeling comfortable using it?
Yeah, it takes a little while, so I don't recommend you jump right into it. I would say a good place to start is start with maybe the simpler cases, the -2 to -4, not a lot of still. Get probably about 10 cases under your belt, understand the mechanics of how Ortho-K works, and then you can jump into it. Now, the one thing that's good, while there is a steep learning curve, all those those companies I mentioned, whether it's Wave, iSpace, or OrthoTool, they do have quote unquote consultants. They help you get into it. So they don't just give you the software and say, all right, go figure it out. They kind of help you wean your way into it. So they have great customer service. So I don't think you have to be too worried about the learning curve. It's just have a few of the easier cases to start off with.
Gotcha. Makes sense. And one more question. What's your favorite drop to use with Ortho-K installation?
Yeah, I like a preservative-free artificial tear that's not too viscous. In our office, we use Optase, and Optase is my go-to, and also Refresh Relieva. The reason is preservative-free drop that comes in a bottle, so they're not worried about using vials. It's just easier for the patient, and it's worked pretty well for us.
All right. Sounds good. Thanks a lot, Anna. That was great. Aaron?
Absolutely. Thank you, guys.
All
Enjoy
right.
the rest of the event.
Awesome. Thank you again. That was fantastic and great info in that 10-minute talk period. All right, we're going to jump into, and once again, Vision by Design. I don't know if we mentioned that yet. Yeah, I think we did, but go ahead and scan that QR code. Fantastic. Coming up in about a month, so you still got time to register. Oh, that's right. We got a raffle coming up. Chris, do you know who our first raffle winner is? Yeah, got to unmute yourself.
Yes.
It's never a Zoom
raffle
until you
winner-
say unmute yourself.
That's true.
Annie Baroni is our first raffle winner.
Annie Baroni, if you're out there, email us, admin@ODsonFinance.com. You just want a $100 Amazon gift card for learning about myopia management. Not about Sunday. All right, let's go ahead and continue on. So we're going to jump into our second hour of Cooper-Proof CE. It's a nice little intermission there, but let's get back into the nitty-gritty. And our speaker for this hour is Dr. Brianna Rhue. So Brianna is from Colorado Springs, Colorado. She graduated from the University of Arizona with a business degree, where she was also a cheerleader. She graduated from Nova Southeastern University and completed her residency at the Bascom Palmer Eye Institute, where she met her husband, Josh, who is a neuro-OMD. She joined West Broward Eye Care right out of residency and became a partner in 2015. She's the co-founder of Dr. Contact Lens and Techify, which was developed from her passion to keep the profession moving forward and help us compete with technology. She's the immediate past president of the Broward County Optometric Association. She has a six-year-old son, Dalton, who inspired her to get into myopia management, and a 9-month-old baby, Brennan. She enjoys standing on her head in yoga, vacationing with her family, listening to technology podcasts, and sharing her passion for myopia management, squirrel lenses, and technology with her colleagues. So Brianna, it's awesome to have you on again. Go ahead and take it away.
All right, guys, happy Sunday. Let me do my share screen. Move you guys out of the way. One more second. All right, we good? You can see it? All right, so excited to be here, as this is one of my passions as well. And thank you to our sponsors for allowing these things to happen. Make sure that you support your sponsors, because that's how we keep this going. So here are my financial disclosures. If you're at Vision Expo West, make sure that you stop by and say hi, and always like to see some familiar faces. So by the end of this presentation, my goals for you and my promises are that you'll really start looking at myopia in a different light. Maybe you'll drink a little bit of the Kool-Aid that a lot of us have drank at Vision by Design. Get back to your why and your passion, and really feel confident by starting with soft multifocal contact lenses, dual focus contact lenses, and atropine, especially if you really aren't comfortable yet, keyword yet, with Ortho-K. So again, you're investing in your future, continue to do so. So thank you for being here. We all have to keep learning, and you just never know what you're going to want to do next. So you always got to keep planting seeds. Myopia control, it's a lot of seed planting. You are going to get a lot of no's as you jump into this, as you get your elevator pitched down. So you're going to plant seeds in your own practice as you go through this. That brings me to this little word, niche, 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 niche. I am so sick, or was so sick of this word until about 2015. I always had this in the back of my head of what was my niche going to be until I actually was pregnant with my now 6-year-old baby. And I did a random Google search because I am a -5.5. My husband is a -6.5. And I said, is there anything that I could do to slow this down or prevent this from happening in my kids? Come to find out, we are light years behind the rest of the world in treating myopia. So again, I'm excited to share this with you. Found my niche here through myopia control. How many times can we say the same thing and count to 2? So which is better, 1 or 2? I now fortunately am able to count to 8, but myopia really, really changed my practice and my vision for myself and for my patients. So type in the chat here, are you practicing myopia management? Yes, all the way, you're doing it. Ortho-k, atropine, soft multifocals, dual focus. You're dabbling a little bit. Number 2, that's why I'm here, is to get started. No, but I want to, or know that this is still some snake oil. So type that in the chat for me here. Couple 2s, couple 3s, couple 1s. Nice, nice, nice. Awesome. So we're here with some like-minded people, which is great.
No 5 so far, which is good.
Awesome. I'll keep those going. So thank you for your participation. It's interesting here as you're on the other side. So another here, let's switch. What is holding you back from starting to offer this to your patients? Is it the education piece? Number 1, I have to still set up my program. That's what's holding you back. I didn't learn this and I'm trying to, which is why you're here. You don't see kids or you don't like to see kids, or you just don't know what's holding you back. Let's jump here to this question. 2s, 3s. Nice, nice. Awesome. All right, so here is a little story for you. So there's this patient, 4 o'clock on a Friday. Happens to be when I actually was going into labor with my now 9-month-old baby. My mom calls me, I'm on my way to the hospital. She goes, Brianna, they were in town for my baby shower that I actually missed. And she said, I am seeing some flashes and some floaters. And I was like, seriously, this is the time this is going to happen? Really? I'm on my way to the hospital, Mom. Well, go into my clinic and let's see what's going on. Well, she's got a superior tear, and now she's on, while I'm on the way to one hospital to give birth, she is on the way to get lasered. So fortunately, she ended up with a nice little new floater and a new little grandbaby. So she is only a -4, and this just continues to hit home in what we do and why we do it. So this is my mom holding my little grandbaby about 3 days after being lasered. So not only do I get to hear about this floater all the time, but now she's got a new little baby. So this -13, this was the actual 4th image I took on my optomap. This is a 28-year-old patient who you can see has undergone scleral buckle procedures in both eyes. You can see really quickly here that she got so lucky because her demarcation lines are below her macula. These are going to be a thing of the past, but we all have to work together. So we have to stop being so myopic about myopia management. It is not snake oil anymore. We have so many FDA-approved treatments and soon to be FDA-approved treatments. And I never want to be that clinician where someone comes off the street asking me for a service that I don't offer or don't even know about. I want to be the one that's leading with the new and greatest for my staff and for my patients. So in times of rapid change, experience could be our worst enemy. A little bit more about me. I was that myope. Here I am in 2nd grade, a -250, and my mom and dad didn't know it. Again, my mom's a -4, my dad's a -250. Really hadn't gotten my eyes checked yet. We're on a trip to South Dakota, and I say, hey, Mom, look at that sheep over there. And she's like, oh, well, we have a problem because that is not a sheep, that is a cow. And so that is when I received this wonderful pair of glasses. And fortunately, my mom got me contacts in 3rd grade because these things were always broken, not only because they were really, really cool looking, but because I was also a dancer and a cheerleader. My myopic passion, again, arose from becoming a mom. So being a -5.5, -6.5, there's my little 1st grader right there, as well as my new little baby. And now we've got some prophylactic treatments that people are dabbling in as well. We also can't open a journal or go online without seeing something about myopia. Now we have Michelle Geller telling us that myopia is all about it. And hopefully I think they made a mistake with Coopervision going with Michelle Geller. They probably should have gone with Freddie Prinze Jr. because those are the 30 to 40-year-olds that we are going after as parents to educate them about their kids. Maybe J&J will get it right. So our digital devices, our digital eras, these are how babies are coming out. This is how we are going shopping. This is how we are going on play dates. This is how we go outside to play. This is a picture that I took. Here's my mom with somebody in Hawaii. And look at this working distance for this kid. We are outside in paradise. And this is how family time is happening. Then we go, again, dinner time. We go and decompress, more screen time. And then to recharge our own batteries, all we're doing is plugging our things into the wall and recharging those batteries. And to make matters even crappier, now we even potty train on devices. So again, I'm all about learning. Where can we learn more? So here are some of my favorite titles and podcasts right now. So I can also you guys can get copies of these slides as well. So there is a new FDA approved treatment with Johnson & Johnson with Ortho-k. So as Paul did a great job explaining Ortho-k and some troubleshooting, there's some really easy ways to get into Ortho-k. So don't let that deter you from being successful or starting. Doing my residency at Bascom Palmer, I was brainwashed to think Ortho-k was bad, until I went to Vision by Design and had just a whole enlightened arena of what myopia management can be and what Ortho-k can be. So you have so many tools, so many consultants, so many people willing to help you get your feet wet with this, and it's not that hard. So the standard of care for myopia management has changed. The World Council of Optometry says that we need to mitigate it, we need to measure it, and we need to manage it. Here's a QR code, excuse me. Here's a QR code that you can scan. It pulls up your myopia guide, and it's a really quick read on how to really get up to speed on how to offer myopia management to your patient. Myopia control versus myopia management. There's a big thing here in the industry on what do we chart or what do we call it? Myopia control versus myopia management. Myopia control is defined as being something that slows down the progression of myopia in age-appropriate children. My site has that designation. Myopia management refers to the decision to implement a strategy to slow down the progression of myopia in a child. Hence, low-dose atropine, Ortho-k, soft multifocals, or dual focus contact lenses. Myopic maculopathy. This is what we're worried about in all of our treatments. Here was a study that looked at what myopic maculopathy was in 2015 and projected it for what it's supposed to be in 2050. Here, we've got 10 million patients that were either visually impaired from myopic maculopathy or blind from myopic maculopathy in 2015. That is projected by the year of 2050 that 55 million people are going to be visually impaired from myopic maculopathy, with 18 million people being blind from myopic maculopathy. I think what happens is we lose connection with these patients because we then have to send them to retinal specialists. Here's a case, 33-year-old presented to my office. We've been following her for some time. She's a -18. Her axial length is 33. She was 20/25 up until about 6 months ago. Came in and said, Dr. Rhue, something's going on. I don't know what it is. 33, 2,400 now from myopic maculopathy. Here, the incidence in the US we know is on the rise. 41.9% of kids between the ages of 5 and 19 are already myopic. So if you're not seeing children, they're out there, and we have to do a better job through pediatricians and other things to get these kids in our chairs. So what is going on in the rest of the world? Here, this is how in Asian countries, they keep their working distance. It must be pretty cold in this classroom because they all have parkas on. Here, we've got this little clip that goes on the side of the glasses. It shows the parents how much they're outside. If they're tilting their head, it vibrates to let the kids know if they're up close too long. They also have public service announcement that they know it is important to get these kids outside. We also have treatments available now. My site's been available in other parts of the world since 2009. We just got it in 2020. That's how far behind we are. Then you've got big names coming in, Essilor, Zeiss, all of these other things. And here, this one is an outdoor classroom that they have. I live in South Florida, so this probably wouldn't work, right? We would just bake our kids to death. But these kids, they understand the importance of real light and getting them outside. So myopia, so what? We've got this 6-year-old kid that presents to our clinic that's a -150. I used to say, okay, no big deal. We know that they're myopic and they're going to keep coming back. Kudos to us. We get to actually see this kid a lot, right? What I now start to worry about and think about is what's going to happen to that kid's future. And I also think to myself, as a 6-year-old, is there something that I could have done sooner to delay this onset for the future? Myopic maculopathy, why the big deal? We are all good as optometrists is educating our patients that are myopic. If you see flashes and floaters like my mom, if you see a meteor shower of floaters that are different, you need to call me instantly, right? Because we know that they're at risk. Myopic maculopathy is defined as having stretched blood vessels, parapapillary atrophy, posterior staphylomas, lacquer cracks, geographic atrophy, subretinal hemorrhages, and choroidal neovascularization. How I like to describe this to my patients is I say, look, your eye is longer than it should be. And what's happening is we have that fine layer of retina back there. And what happens, it's like these fitted bed sheets that we all love to fold. If you think about it, if I'm doing this stretching, that's actually what we're doing to the retina. And we get these little micro tears right there in the macula. And that's what leads to the problems. That's what we want to prevent in your kids. I don't go into more than that. I don't want to scare the parents of what could happen, but that's just a visual that I can give them on what actually is happening. So myopic maculopathy, Justin Kwan kind of hit on this, where the average age of myopic maculopathy is 47 years, plus or minus 14 years. So my patient that was 33 falls into this. Now we're worried about her other eye. And the average visual acuity for somebody that develops myopic maculopathy is 20/50. Can't really glue the retina back together. It's good if they get a retinal detachment because most of the time we can fix it. Myopic maculopathy, on the other hand, not so good. So a disease, we're saying myopia is now a disease. The definition of a disease is a disorder of structure or function in a human that produces a specific sign or symptom that affects a specific location, in this case, the eye, and is not simply a direct result of physical injury. We've got our old definition of myopia, which is a refractive error in which rays go in front of the retina. There's now a modern definition, which is myopia is a chronic progressive disease characterized by excessive eye elongation, risk of associated sight-threatening complications, and they put the negative powered refractive error at the end of this definition. The game plan that you should have for bringing myopia to your clinic is first you got to commit. You got to say that you're going to do it. You got to want to see kids, analyze your practice, educate yourself, so you're all here to do that. Build your program, staff training, invest in equipment, have your myopic exam down. You got to select your treatment, and then you got to have your elevator pitch. So I'm going to say it. We're all salespeople here. You may not like that word, but that is what you're doing, is you are selling a vision to your patients, and they need to believe in it. So where do you start? You got to think, analyze, plan. You may get stuck in this analysis by paralysis. Find your tribe, find a network of people. That's again what Vision by Design did for me, of people that really, really love this. You are learning from the greatest minds, and they are there to help you do it. The goal for any myopia treatment is to keep the myopia below a -3 and axial length below 26. Single vision glasses, we know they don't work, yet 80% of practitioners acknowledge this, and 64% of myopic kids around the world are still treated with a single vision option. What I'm seeing around my area is doctors are waiting until they see progression, and they'll see them as a -2. They know they're going to see them in a year, and they're going to be, who knows, -3, -4. They're going to wait another year, see them as a -3 or -4, and then they're going to say, oh, well, I guess this is progressing. Let me refer them to somebody, because I don't do it. We've got to refer these patients earlier. So if you don't want to see kids, that's okay. Find someone in your area that does. Trade off. If you like to do dry eye and you don't like to do myopia, here are those crosstown referrals. The future for optometry is super, super bright. 60% of my income comes from my optical. I get it. And we're making that up in charging for what our value and our worth is. Again, kids, I've said it before, you gotta like and want to see kids in your clinic. Go and analyze your practice. 70% of your clinic, of the patients that you see every day, are myopic. That is where we're fitting our contact lens patients. That's where we are fitting our glasses patients. That's what keeps our opticals healthy, are those patients. 20% are hyperopic and 10% are emmetropic. And I actually want to grow the emmetropic side of my practice. I may sound crazy, right? 60% of my income is coming from one thing, but it actually, you're going to get back to your why and charge appropriately. And you're going to not only be taking care of these patients, but you're going to be making more money. And don't give up on your contact lens patients. Don't let these people walk out of your door. Your 30 to 40-year-olds are the ones that are going to build your dry eye clinic. They are going to build your myopia clinic. They are going to build your aesthetics clinic. So make sure people can easily order contact lenses from you. Here again, we've said it many, many times already. Educate yourself. You've got the Brian Holden myopia course. You have myopia profile, Vision by Design, review of myopic management, bullers2020.com, where he looks at and reviews all of the latest, greatest research. Get your MySight certification. So being able to assess the risk factors, I'm not going to go really heavily into this, but we've got a lot at play. You got genetics, near work, outdoor time, education, ethnicity, age of onset, and other things like prematurity, diet, and light exposure. Cycloplegic refraction, if you don't take anything away from this, these are your myopes. So I have this on a little grid in my office. It's a two-sided double sheet where I show the patients and the parents where they are on this curve. So a 6-year-old should be scoping about a +170 to +150. If they are scoping a +75 or less, that is your nearsighted patient. Instead of seeing them back in a year, see them back in 6 months and charge them for the visit. This is how you build your clinic. Your 7-year-olds should be scoping a +150 to 1.25. If again, they're scoping less than this, these are your myopes. These are your pre-myopes. I use tropicamide 1%, 2 drops, 5 minutes apart. And again, you're going to follow up with them sooner instead of every year. Your pre-myopes, independent of family history, ethnicity, and other optical and environmental factors, if they are a +75 at 6 to 7-year-olds, those are your myopes. Brings me here to one of my favorite things, which is axial length. Just like we learned pachymetry, you can learn axial length, and you're going to learn it right now. Super, super easy numbers, okay? Emmetropia should be between 23 to 24. Make sure that you're looking at the eye as a whole refractive process, right? We have eyelids and lashes, tear film, cornea. Then we have your anterior chamber depth, your lens thickness, your vitreous chamber depth, and then you have your choroid. So think of this as all a visual pathway. If you know one part of the pathway, but not the rest of it, where are you going to go? So it's all combined. Axial length, I think, is one of the most fun measurements that you can do, even on all of your myopes, to show you what kind of myope they are. So in the chat, do you have an A scan? 1 for yes, 2 for no, 3, I'm looking to get one in the next 6 months. See what we got. So it's interesting thinking about this as you guys put in your answers. 312. If you treat glaucoma, you have a visual field, an OCT, Goldman, and pachymetry, right? You need all of those things to treat glaucoma. Can you start a myopia clinic without a scan? Yes, you can. But if you want to get serious with it, invest in this piece of equipment. You can start off very little, and I'll show you why. So again, being married to a neuro-ophthalmologist, I get to look at lots of scans, and he knows I am obsessed with long eyeballs. This is a picture that he shared with me. This was one of his patients that is a 29.4 millimeter myope. And you can see how long these eyeballs are in the socket. Here is another one. Look at this one. This patient is a -4 in this eye and a minus, I think it was only a -14. And you can actually see the scleral buckle right here. What happens here is look at these nerves. They are called tilted or kinked optic nerves. The eye is shoved into the back of the socket because it's so long and it doesn't have anywhere to go. So when they present to my husband with double vision, they get something called heavy eye syndrome. Never knew what this was until about a year ago. What it is the eye is so big, it can't actually move in the socket. So the muscles get stuck as well. So it's really, really hard double vision to treat. This again is what we as a profession have an opportunity to prevent. Axial length, here's another one. You can take a snapshot of it. Girls and boys, European and Chinese eyes are a little bit different. 6 to 7, they should be measuring about a 22.75. If they're longer than this, this is your myope. 8 to 9, again, they're going to grow because we're growing. Our feet are getting bigger, just like our eyes, but we don't want them to abnormally get big. One thing here, in Chinese eyes, there's a new study by Dr. Liu, where she was saying is she looks at the scleral fibers. In Chinese eyes, the scleral fibers are actually not as bound together. And so their scleras are actually weaker. And so if you're doing a lot of reading and up close in this working distance, your eyes are saying, hey, I want to be stuck here. Hence, you become myopic because it's easier for your brain to see and function versus us being hunters and gatherers, which we were for so long. That's why we saw this huge increase in myopia. So here, this is me and my little guy. This is Dalton. His axial length as of 6 months ago is 22.92 and 22.94. And myself, I'm a 25 millimeter myope. So I'm in kind of that danger zone. He's a +1, I'm a -5.5. We are again watching him and most likely are going to prophylactically treat him. Here's the myopia.care. You can see where I graphed Dalton right here, that little dot. That is him. It's showing me that he's already in this danger zone of becoming myopic. So how easy is it to measure? Here is me measuring, if I can get this video to play. Oh no, it's not going to play. Oh, boo, sorry. So what I do is I have a contact tonometer. It's a 6-year-old little girl here that we were able to get, and they hold still for it. I do like contact in my clinic because it's going to show me what kind of treatment I'm going to go for. If I can get this measurement on a 4-year-old, and it's very repeatable because I do measurements myself. If I can get it on a 4 or 5-year-old, I'm going to talk about contacts, whether it's ortho-k or soft multifocal. If I can't, then I'm going into atropine. And so it shaves right there off a ton of time on what I'm talking about with the parent. So axial length devices out there. Yes, you've got the DGH ScanMate, you have the Aladdin M, you have the IOL Master, you have the Lens Star, and you also have an Oculus that you can get it. So if you're looking to dabble, you can get some of these instruments for really, really inexpensive, and ODsonFinance has a great special that you can get for the DGH. So here is showing you a spherical equivalent graph and an axial length. Look at these kids. The earlier that you start to become myopic, the more myopic you are going to be. Again, the earlier you start with myopia, the longer your eye is going to get. Yet here, children that develop myopia between the ages of 7 to 9 years old have a 54 to 80% chance of progressing past a -5. So axial length and refractive error, I'm going to harp on this a little bit more. It really matters because you're going to either be really aggressive or not so aggressive. Here, same refractive error almost in these two kids that are both 11. This little one is a 24 millimeter myope, not that long. K readings are actually, she's pretty steep, right? -550, his axial length is 27. That danger zone again is over 26. That's where all those risk factors go up. So really refraction and axial length, if you're doing one without the other, you're only really looking at half of the story. Here again, to get my point home, 24 millimeters on this -4 eye and a 27 on this eye. Same patient. This eye is a -12. And you can see in the fundus, again, we're really good at telling our myopes what they need to be careful of. What's normal on axial length? Up to age 12, a 0.1 millimeters per year in growth is normal. Greater than 12, they're going to kind of grow a little bit, or sorry, if they're less than 12, they're going to grow a little faster. If they're greater than 12, that's kind of when they slow down. And 0.2 millimeters, you're going to monitor them closely. We're all really, really good at measuring diopters. Now we got to get better at managing axial length. If you go over 30 millimeters, there's a 90% chance that you have, this was a study that looked at 10,000 patients, 90% of those people by the age of 75 were visually impaired, 25% over 26. Where's my clinic at? This is actually a study that I looked at from 110 of my patients with a refractive error of +75 to -21. 22% of my patients are in that danger zone, and 78% of them are okay. So again, your goal here is to keep the myopia below a -3, which means we got to start earlier, and below a 26. Here's another one about axial length. This was a parent that came to my clinic super, super worried. They went to another clinic, got really, really scared for their 5-year-old son. Current spectacle RX was a -8 and a -5 with a little bit of SIL. My refraction that I got was a -10 and a -550, so it was already undercorrected a little bit. We're not going to undercorrect anything. And cyclo was pretty dead on. So I said, well, I only have half of the story. Let's see what's going on. His K readings, super, super steep, 49. Axial length was not that bad considering he's a -10, right? Yeah, he's still in that danger zone at 25. But my conversation goes a little bit differently with these parents. They were terrified. Our goal is not to terrify them of their kids going blind in the future. It's about education. So here, again, his optic nerves don't look that bad. His retina actually looks really, really good. And so what we've done is we started him on 0.025% atropine. He's got a little lighter eyes, so I felt comfortable with that. And he's actually holding pretty stable. So here, type in the chat, what's your prescription? You're hyperope, you're plano to -3, -3 to -6, -6 to -10 with a 4. And if you're over a -5, you're over a -5, just go ahead and type in what you are. See what these numbers are. You know, for dealing with myopia, we're all pretty myopic, aren't we? So we have an opportunity here for the story, right? I always say, look, your kids are not going to end up like me. That's the story. That's the connection. That's the sale to the parent. So I hate to break it to most of you here, but we're in some of these risk categories right here. We've all seen this chart. If you're less than a -2, which is 60% of myopes, they still are in a higher risk category here. -2 to -6, they're at a 10 times greater risk factor, and -6 or 10% of the myopes at a 41 times greater risk factor. And if you're over a -9, you're at 348 times greater risk factor to developing myopic maculopathy. So also we know with cataracts, the odds of your PSC go up, or developing a PSC go up as well. And it also, the surgeons don't like doing these types of cases because the lens zonules are actually weaker. PSC cataracts, we all know that they grow faster. They develop at a younger age. They can adhere and weaken the posterior capsule. They increase the risk of posterior capsular tears. And then myopes lens zonules are actually more fragile and weaker. So the different treatment options, we're not going to do nothing anymore. So we've got 5 pillars to myopia control. We've got the screen time, outdoor time. So even if you're not practicing anything that we're talking about today, just by getting these kids outside, you are treating myopia. You have low-dose atropine, dual-focus soft multifocal contact lens, ortho-k, which Paul and Anita both alluded to, and then combo therapy. These treatments on your left here are more associated for your pre-myopes, and the ones on the right are obviously associated for your myopes. So some parents, they are going to beat you up. You've got to be prepared for these questions. Can we wait to see what happens? Why is it so expensive? Does my insurance cover it? Why have I not heard of this before? Why should we be controlling myopia? Make sure that you know all of these questions. I literally got hit last week by a parent that asked me every single one of these questions. And she walked out saying no to my face, and she's a -9. And she's got a kid that's 8 that's a -3. So some of these you just got to let walk. That's okay. You're going to just brush it off and you're going to do the next one better. Screen time recommendations, the American Academy of Pediatrics, if you're 18 months or younger, no screen time. As a mom of 2 boys now, I used to give patients the benefit of the doubt, or parents the benefit of the doubt, that it was harder than it is to keep your kids off the screen. It's not that hard. So we've got to be involved in this process. My kids have seen 5 of the pediatricians in the pediatric office. Not a single one of them in 6 years has mentioned screen time recommendations to me. We can do better. So again, small working distance, talking about working distance and getting them outside. Your myopic exam, you're going to change this a little bit. What I do is take a brief, or actually a pretty in-depth history, the age of onset, visual acuity, corneal topography. You're looking at pupil size for dim and light, a binocular vision assessment, looking for lag, if they're esophoric and what their ACA ratio is, looking at axial length, taking photometry, right? That's going to matter as they get older. We know for glaucoma, your objective and subjective refraction, and anterior posterior exam, and your IOP. Here, to just harp on screen time, there was a study done, it's an older study, but Sydney versus Singapore. The kids in Sydney were actually outside 4 times as much, but on the computer more, versus the kids that were in Singapore. And look at the incidence of myopia. This screen time, outdoor time does matter. So we've got this 20-20-20 rule that we all talk about. I have now changed mine to the 20-22 rule, because we know that 20 seconds is not enough time to actually relax out the focusing system or the accommodation system and undo what we've done to the choroid and the sclera. So getting outside, we want them to be outside here. I was just on a trip to Arizona, and this is how we approached this playground. It said, get outside, but we want you to be on your phone playing outside. This is ridiculous. So I don't know what the fight is against all of this, but we do have to educate them to be outside. By getting outside 40 to 80 minutes a day, we also don't think that it's just getting outside for 3 hours at a time. It's got to be broken down into bite-sized pieces to get outside. So 20 minutes here, 30 minutes there, 20 minutes here, breaking up what's going on, and it can reduce the incidence by 23 to 50%. Some outdoor theories, we don't really know yet. Could be the light level, could be the dioptric field of view goes to 0, could be, here again, we're not focusing on accommodation. The light dopamine theory, which is when we go outside, our retinal cells release dopamine, which prevents the eye from growing. We do know if you live in winter months where there is winter, I don't live in winter, but it actually progresses faster. And we are also looking at the choroid. So again, if the choroid thins, then the eye grows. If the choroid thickens, the eye doesn't grow. And don't forget about the lens. All the visual system here. Emetropia, the eye grows 0.1 millimeters per year, and the lens thins and flattens. When the lens can't thin and flatten anymore is when we become myopic. So some of our new instrumentation for axial length is going to find these little changes. So let's get into here. So atropine. Here's another little quiz. Do you think that it's safe? Yes, I prescribe it. Don't know enough yet to say yes or no. Number 2, no, I don't feel comfortable in prescribing it yet. 4, I need more evidence to say that it's safe. Or 5, I'm waiting until FDA approval to prescribe it. Got some 1s, some 2s, some 3s. Nice, nice, nice. All right, so this is an easy place to start, is atropine. So atropine has actually been known to prevent myopia development since 1874. Yeah, I said 1874. So centuries, this has been known to prevent myopia. But we know at high doses obviously create blurred near vision, light sensitivity, and myopic rebound. The atropine theories, we don't really know. We think that it is actually binding to the scleral receptors to prevent the choroid or the sclera from thinning. And that actually is becoming more and more evident as we're doing some studies with the choroid. So think of it like cross-linking, right? We're sending these keratoconus patients for cross-linking. We're doing the same thing here with a drop. Low-dose atropine, it's been studied for, again, decades. Atom 1, Atom 2, Atom 3, the LAMP, the STAR, the Chaperone study. You got to look at all of these studies with kind of a grain of salt. There was a lot around the LAMP study pretty recently as well. So we'll go quickly through some of these. The Atom 1 enrolled 400 kids, -1 to -6. What it showed is it worked, but they got some rebound. All of these kids had to wear photochromatic glasses, and they were on 1% atropine. To put this in perspective, I just saw a kid that's 10 years old. He's been on 1% penalization atropine therapy with the pediatric ophthalmologist for 10 years. 1%. What we are doing in these studies is we're diluting 1% with 100 drops of saline to make it 0.01. There's nothing really going on pharmacologically here that we need to be worried about. Perfect, thank you. The Atom 1 results here, again, it showed that it worked, but 77% of them rebounded. Atom 2 looked at 0.5, 0.1, and 0.01. And we had a 24 months of treatment, a 12-month washout, and then those that continued progressing, they put them on atropine again. The 0.5%, 68% of those kids had to go back on atropine, and they put them on 0.01%. 0.1%, again, that little bit of rebound, and 24% of them with 0.01%, so a lower rebound. Again, it worked. It slowed down the progression. So the Atom 2, the 0.01 was the winner. The Atom 3 study, I'm super, super excited about. They just finished it, but with COVID, everything kind of got extended. We're expecting results in about 2023. Look at what it's looking at. 5 to 9-year-olds, one parent with myopia with the spherical equivalent of +1 to -150. This is prophylactically treating myopia. Remember, every year that we can delay the onset of myopia, we get it all on the back end. So we need to own this. Pediatric ophthalmologists are prescribing atropine in droves, and they're not charging their patients appropriately, and they're not seeing them like they need to. This is where we come in. So don't be scared to prescribe atropine. You just need to get a compounding pharmacy, get it in your contract that it's off-label. We use off-label treatments all day long. The LAMP study here, again, looked at 0.05, 0.025, and 0.01. 0.05 was showing that it was better, but ended up being still 0.025. The STAR study is looking at 2 doses as well. I am part of the STAR study. In my clinic, we've got 21 kids enrolled, and we should be having atropine approved here in probably the next year to 2 years. The STAR inclusion criteria, I will say, we enrolled 2 3-year-olds in the study. This is safe. It's not compounding. So 0.01%, it wears off in about 12 hours. 0.025 wears off in about 15 to 16 hours, and 0.05 wears off in about 18 to 19 hours. So you're not compounding the drop in the eye. Low-dose atropine, here's a case. 7-year-old plus 50, wasn't really doing myopia management at that time. Obviously, he progressed. He's been on 0.01 for quite some time, and he has not changed. And then again, you can see when I got my axial length measurement device here. Here's the Brian Holden calculator. This is, again, putting in an Asian. This is this little kid, 8 years old, -1. If he's a -1, he's going to end up somewhere between a -2 to -4. If we treat him and keep the control at 59%. If I don't do anything, he's going to end up somewhere between a -4 to a -750. Atropine treatment protocol, I do 1 drop 0.025% daily. I started in kids as young as 3. And I don't wait for progression anymore. I know that they're going to progress, right? My crystal ball works that well. You're going to treat for at least 2 years or up to 15 years of age. So what I do in my atropine evaluations is I see them back for my 4-week follow-up just to make sure they got the drop. These are your glaucoma patients that are non-compliant. So you got to just make sure that they got it. I'll see them back at 3, 6, 9, and 12 months for that first year. And then I typically go to every 6 months. Again, Cleopatra, used atropine, right? Concentration debate, which one do you start? 0.01, 0.02, 0.025, 0.05. What you're looking for is for the 2 millimeter pupil dilation is to know that you've got enough treatment. So if that is a blue-eyed baby, maybe 0.01 is enough, right? If it's an Asian eye with really dark irides, 0.05 is probably where I'm going. Here, controlling the peripheral defocus. So we've got things that do this. You have ortho-k, you have MySight, you also have natural view. Remember what we're doing here with myopia is if we think of these rays as behind the retina, we think that we're actually elongating the eye. So think of it like a screen, right? If you move the screen back, you need to refocus, which is stronger glasses. If you move it back again, refocus, stronger glasses. What we want to do is focus these rays in front of the retina with clear distance vision. So are you prescribing dual focus or myopia controlling contact lenses? 1 for yes, 2 for no, 3, I have a fit set, but I haven't started yet. 4, I want to, but I don't know what to charge. 5, I want to, but don't know where to start. Some 4s and 5s. Gotta get. Awesome. So here, Paul Gifford's study, it was the Blink study. It looked at the biofinity multifocal contact lenses with a +150 and a +250 center distance. Really had no effect. The MySight slowed it down by 59% and axial length by 52%. So if you have the multifocal fit set for biofinity, you're doing something here, but again, you can do better. You also have the natural view in your back pocket as well. And the parameters go up a little higher if you're capping out at that -7 for MySight. And what it does is it gets that inside pupil ring. It gets actually the effect that you need to create that peripheral plus. The power profile, again, a lot of plus right where you need it in these eyes. MySight approval, had approval in November of 2019. It's got 2 rings of focus that are difference between plano to +2. So you're creating 2 zones right in front of the retina. Again, 3-year study, it slowed progression by 59% to 52%. I think the hardest part to do here is learn how to charge and present your fees. That's the hardest part to this. You can fit contacts in kids. I've got multiple 6-year-olds in this lens that do phenomenal. So you know that you're doing something. And if I can sell 1 year of myopia treatment to these kids, I've actually changed their endpoint, right? So that's where you get a lot of the changes happen in that first year of the graph. So here, to point out my point here, the top purple graph was the MySight kids. The bottom one is they actually were in the ProClear daily lens. And you can see the treatment here, what they got. The MySight group that was in lenses for MySight for 6 years only progressed 1 diopter, less than 1 diopter in 6 years. Here again, axial length, same thing. These kids didn't really progress. And what else was interesting here is 23% of the kids in the MySight 6 group progressed by only 0.25 diopters. Again, it fit it like a single vision lens. This is not hard to do. The hardest part is presenting your fees. And if you look at this, the MySight kids that were in ProClear, they progressed in 2 years, with the MySight kids progressed in 6. Again, very safe in kids. You can get over fitting contact lenses in kids. That is the way to go. 7.4 in 10,000 cases. Here's a soft multifocal case, -150. He progressed to a -4. Again, lost him to follow-up. He was progressing more and more. And now that little kid's been stable and he already capped out at what this graph was showing. If you've got kids with a lot of astigmatism, either go to ortho-k or you have something like the synergized lens. I can get around a -1 to -1.25 sill with really good success between both my sight and the natural view lens. And I'll end up here on the ortho-k. One thing that really changed my mind about ortho-k is, remember, you're not touching the central cornea. Here, perfect. The ortho-k lenses, think of it as a human hair is 70 microns thick. This is something, a little tidbit I got from Vision by Design. You're only compressing the central tissue of the epithelium by 10 microns, 10 to 12 microns to mold a -5. So let that sink in a little bit. How to bring myopia management to your practice. You've already got a myopia clinic, just go after it. And I will tell you, in order to be successful here, you've got to have both parents present to be successful. And I learned this from my father as a furniture salesman. He called these a one-legger and a two-legger. If a one-legger dad or a parent or a mom or whatever walked into his furniture store to buy furniture, they could get out of the sale. So that was his one-legger. If he had a two-legger, it was a couple that walked in. And he's like, I gotta go, I'm gonna close this sale. So if you don't take anything from this, your success is going to come from getting both parents on the phone, whether that's for a consult, FaceTime then and there, or in the future. And this is how I grew my myopia clinic. I take a Polaroid picture of every single kid, and everybody walks down this little path to go become a patient in my practice. Oh, you see kids here? Why, yes, we do. So show people the type of clinic that you want to have. This $50 camera has returned dividends on it. So develop your program before you start, evaluate your chair cost, develop your handouts, your contracts, your compounding pharmacy, your ortho-k. Have some patience. Don't get discouraged by a no, and just do what you know that you got to do. So here, I'll end here, completing that circle of myopia management. You get your first pair of glasses, then you get your contacts, then they're interested in refractive surgery. Then they go to get refractive cataract surgery, and then sometimes they're going to end up with a retinal specialist. We're a part of this process. So please do something, educate, refer them out if you're not going to do it, manage it, assess these risk factors. There's no cookbook approach yet, but don't dabble in myopia management. So challenge yourself tomorrow to be 1% better than you are today. So are you going to change something tomorrow? It's Monday. So a 1 for yeah, let's do this. Let's bring on some myopia patients. 2, I'm not yet, still need some more info. Not yet, I still need to set up my program. I'm going to change one thing tomorrow, but it's not related to myopia. Or let me go check with my staff and see if this is something they want to do. So what are you guys putting in the chat? And this is a huge gift, and I'll leave it on this note, is think of the 6-year-old that you see today in your clinic. In 30 years, they're going to be 36. In 30 years, they're going to be 66. We are 2 generations of optometrists that you get to change today by doing myopia management. And you are going to help that optometrist not have to give bad news to 2 and 3 generations behind us. So that's a big thing that we get to be a part of. So that's all I got.
Brianna, that was awesome. We have a lot of questions and we only have time for a couple. We'll save the rest of them for the Q&A at the end. Nice handstand. So you mentioned earlier on in your talk about referring to other providers, and unfortunately, as ODs, we tend to not be the best when it comes to intra-professional referrals. Yeah. So how do you successfully get referrals from other providers?
So what I do, I've just become in my, like down in Broward County, there's 400 optometrists. And we all want to specialize in something. And so I have not really gotten my dry eye stuff off the ground yet, but there is one that they do. And so that's where a lot of these inner referrals have come from. And so people know I like to see kids. That's one thing. And if they don't, then they know that they're actually doing a disservice to the patient too. And I've had so many people just say, parents walking in and saying, well, what can I do? And now they're saying, okay, well, I don't do this yet, but go here. And that parent is so grateful. So just put your shoes in that parent's place on, if you can't offer this yet, that's okay. And I've gotten so many clinics on board down here. There's so many people in this community. There's so many myopes to go around. We shouldn't be scared of eating each other's lunch. There's a lot at play here, and this just shouldn't be it.
Yeah. One more question, and I think I already know the answer to this, but someone asked, is measuring axial length necessary for myopia management, or can you do it based off refractive error?
Not in the beginning, you can get a clinic going, but I think I kind of drove home there that, again, it's a whole visual pathway to whole visual system. And it's a really, really fun measurement. So even like my 35-year-olds, right, I'll charge for that. And I'll say, okay, well, you're a -5, that's a 27. Let's do an OCT and a baseline visual field. Let's see kind of where you're at. So I'm able to actually additionally add to my clinic in that way. So a little piece of advice there, or a little, again, investing in yourself. I'm a big investor here on ODsonFinance. This is an investment in yourself for your patient. And my biggest thing to my patients, they always say, you know, you guys always have the latest and greatest. My thank you to my patients is always, you invest in me, so I invest in you.
That's awesome. Great talk.
Thank you.
Aaron.
Yeah, fantastic talk as always, Brianna. That was the first time you gave that lecture, right? That was a brand new lecture. Yeah. So to everyone out there, you're the first ones to hear it. So once again, fantastic. And Brianna will be back on for the panel in just a little bit. All right, so we're gonna have a quick intermission before we go into our last hour of COPE approved CE. Now, exciting news, thanks to Chris talking to Paul, who actually happens to be the president of AAOMC. We got y'all a discount for Vision by Design. And so I spliced the slide in just a couple minutes ago. Use ODsonFinance as your code and you're gonna get $100 off. You gotta do it tomorrow though. They haven't put this all into the system yet. So scan the QR code, save the URL, and then if you're interested in attending, log on tomorrow, put that code in, and you'll get $100 off your registration fee. I'll leave that up for just a few seconds. And then is Russell here? We got DGH coming up. So I know we were just talking about an A scan. And so we've got a quick presentation from DGH, which has been fantastic. I know Brianna has it in her practice. I have it as well. So Russell, I'm going to let you take it away.
All right. Can you see my screen?
You're good.
Okay. So this is, my name is Russell Schlage. I handle the eastern half of the United States. And then we have Raffle Ramirez, which is the western half of the United States. I'm in Florida. I'm pretty close to Brianna Rhue's practice, and Raphael is in Southern California. So we did this presentation at the last meeting. We're going to do something we're going to go a little bit different direction today, because a lot of doctors tell us that they've heard in different lectures that ultrasound's not accurate, ultrasound's not repeatable. If you're using ultrasound, you might as well flip a coin and things of that nature. The one thing I say about accuracy, if ultrasound was not accurate, there would be hundreds of millions of people around the world with incorrect IOL powers in their eye. So that's certainly not the case. Our unit is portable. It's small, so it doesn't take up the space that the optical biometers do. And we have some unique features which enhances the accuracy and repeatability of our A scan that other ultrasound A scans do not. We have a unique alignment algorithm. We analyze each measurement obtained and rank it with a star ranking. We have the only A scan that has an adjustable corneal compression lockout, and that's extremely important. And we have an axial length progression report. So as far as the corneal compression lockout, the #1 operator-induced error in performing contact A scan is that you're applying too much pressure to the cornea and you're actually getting a shorter than true measurement. This is where our adjustable corneal compression lockout comes into play. So we did an in-house measurement data analysis, and it was on the same eye with the same operator, 80 measurements in 1 month. We did it over the last month, so we did it pretty quick. It was in contact mode, and repeatability we got was plus or minus 0.025 millimeters. And this is comparable to the repeatability of most of the optical biometers out there. And in saying that, the operator who did this is the vice president of DGH. And he's a 75-year-old guy, so he is not the best at performing A scans. And this is what he was able to achieve. Now, I know you just heard from Dr. Rhue, and we are ongoing a study. I wouldn't really call it a study. We're doing an evaluation in her practice now. And what we've done is we set her up with a system that we did not intentionally optimize the corneal compression control to see what we would get. And as you can see, in the total of 79 eyes, ages 5 to 65, we got a plus or minus of 0.045 millimeter range. But in the younger people, this was very interesting. It actually got better. We're only at 0.030. So we do have some information, and I do have the references down below where this information came from. From these 4 optical biometers, I do not have repeatability information on, let's say, the Myopia Master from Oculus or the Topcon Maya or the Aladdin. But if the unit is optimized and performed properly, this is the type of repeatability you can expect. Now I think I can get Brianna's, there we go. So the total applanation time there was about 4 or 5 seconds. And then we've also got Dr. Fan doing a scan here on one of her.
Okay, Michelle, blink a couple times and look straight ahead.
One of her employees.
Big and wide.
That was pretty quick.
Okay.
So when I talked about earlier, we have this measurement analyzation system. Every measurement that's captured by the unit, you can see in this little table over here, is analyzed by the computer and assigned 1, 2, or 3 stars based on the quality of the waveform. And the waveform here is the cornea, and the probe is the first spike or echo, anterior lens, posterior lens, and then the retina. So when you hear that distinct double beep at the end of those 2 scans you just saw, that's telling you that all 8 of the scans achieved a 3-star ranking, which is the highest quality measurement. It was under a preset standard deviation, and that the cornea was not compressed based on where the corneal compression sensor was set. We also have an axial length progression report. Now, this one is just a mock-up that we made up. This would be over many, many years of having scans done, but it gives you something that you can show the parents, because obviously it's the parents that you have to convince that there's something needs to be done or intervened. So we do have a special for the ODsonFinance attendees. The list price is $4,000. We have an ODsonFinance special price of $32.95 with free shipping, and we do have to collect sales tax in a couple states. So to sum it up, the unit is accurate. It is accurate to 100 microns. Now, 100 microns is basically the thickness of a standard sheet of printer paper. It is repeatable. It's easy to use. It's obviously portable. It's obviously affordable. And the report can be saved as PDF and put into your EHR. This is a USB device. It does plug into your computer. So to sum this up, the ScanMate A-Scan from DGH is an affordable alternative to more expensive optical biometers. Now, you can find used units out there. You can find 15-year-old Zeiss IOL Master 500s in the $10,000 to $15,000 range. Zeiss does not support them. You may be able to find people that will service them, but it's a crapshoot. And that's it. I appreciate everybody's time, especially on a Sunday afternoon.
All right, awesome. Thank you, Russell, for that presentation. And let me jump to your slide real quick. So once again, if you want to learn more about DGH, feel free to scan that QR code right there. You can reach out to Russell, and we've got a fantastic deal. So take advantage of it while it lasts. I know a lot of you have already. All right, and we are going to jump into hour 3 of Cooper-Proof CE. Now, I know we're running about 5 minutes late, so if it hits 12:05 and Gary is still talking, feel free to leave. You will get your Cooper-Approved CE at that point. You'll be present for the majority of the lecture. So if you got to go, I understand, especially East Coasters, because it's a little later. So once it hits 12:05 Pacific or 3:05 Eastern, feel free to jump off if you need to. And Dr. Gary Gerber is going to be our final speaker. We originally had Ton Mai, he couldn't make it, so we got the granddaddy of the business of optometry here. We got Gary Gerber. He's the co-founder of Treehouse Eyes, the country's first center dedicated exclusively to providing myopia management services to children. He's also the founder and chief dream officer for the Power Practice, a practice building and consulting company whose mission is to help doctors power their professional and personal dreams. Dr. Gerber is also a prolific writer and speaker, as well as an accomplished mentalist and magician who uses illusions to help illustrate his key learning points as well as entertain his audiences. He has authored hundreds of articles and given more than 500 thought-provoking and enlightening presentations. All right, Dr. Gerber, I'm gonna let you take it over.
Thanks, Aaron. Appreciate the introduction, other than the granddaddy part. I'm not that old, but thank you. Thank you nonetheless. Great to be here. Great presentation so far. I'm glad I went right after Brianna because it was an awesome segue. She spoke about investing in your practice, which I certainly believe in. Investing in your practice, invest in yourself. And you listed some of my previous accomplishments. I had a private practice for about 22 years. I had the Power Practice. And now Treehouse Eyes, and every one of those is really kind of living by this J.P. Getty quote, which is doing it a little bit different than everybody else. And that was a nice tee up from Brianna. She started her presentation by asking you guys on a scale of 1 to 5, where's your thinking? Already doing myopia management was number 1, and 5 was snake oil. I'm going to give you content mostly for the 2s, 3s, and 4s. You're not there quite yet. You need some help. You're not sure how to do it. And I want to speak about the economics and the numbers side of it. And from a perspective of co-founding Treehouse Eyes, that's where the content comes from. A lot of times you go to clinical presentations and you'll go to a presentation, for example, on myopia management, and they'll put up a case study and they'll say, this case has to be done with ortho-k. And what they're really saying is, me as a practitioner presenting this case, I'm most comfortable using ortho-k. What I want to give you is the information from a Treehouse Eyes perspective. We now have almost 70 locations across the country. We're about 24 states, and we treat over 6,000 kids. So I want to give you that information. And there is getting close to a cookbook approach that we have for our practitioners. I'm not going to discuss clinical content, but when I talk about the money side of this, we do have a very successful cookbook approach that works across a wide swath of practices. That leads to my financial disclosures. There really were too many companies to list, because if anybody's in the myopia management space, they have been coming to us, which has been pretty gratifying. When we launched the company, we had our 6-year birthday last week. When we launched the company, we were in the unenviable position of being the first one. So we had to go out to companies and contact them. Now they're coming to us because we have such a huge database of kids. And on a practice management side, such a huge database of successful practices. So that's where the content is coming from. It's not an N of 1, it's an N of a gazillion and a lot of years of work. Here's our one of our 2 flagship centers. This is in Bethesda, Maryland. We have 2 centers that are company owned. We use as our kind of learning labs and the kind of starting point for everything we ferret out to our network of doctors. And just some pictures of some of the happy kids around the country that are supporting our mission of being myopia warriors and clamping down and not letting myopia get worse. And if you want to learn more about us, growmymyopiapractice.com is where you want to go. So I want to get into the content. Now that we have all those disclosures out of the way, you know where the content is coming from, I'm going to jump into the meat of the presentation. Since it's ODsonFinance, and you guys talk a lot about what stock should I buy, where should I invest, I don't have to explain what these abbreviations are because everybody knows. The first one is Apple, for example. So I would like you to put in the chat box, if you were going to buy a stock tomorrow at the opening, when the stock market opens, which stock do you think tomorrow is going to have the highest return in the next 20 years? And since we're all ODsonFinance people, we should have that just like that. Now, I'm going to close the presentation. I'm going to give you the answer because I happen to know, Aaron mentioned that I'm a mentalist, not a mental case, but a mentalist. And mentalists predict the future. And I actually have on my desk, I have a crystal ball that helps me predict the future, as every good mentalist has. So I will give you the answer at the end, but I'm curious to see. Let me just open up the chat room real quick and see what we have here. We're getting a mix. We'll have some Bitcoin believers in there. Yeah, we got a pretty good mix. Okay, like I said, I promise at the end I'm going to give you the correct answer, and there actually is an answer to that. As a practice management guy and a former practicing OD, and now with a video that's out of focus, there we go. I really believe you can add pretty much anything to pretty much any practice. It doesn't matter where you are in the country. It doesn't matter really what demographics are. You've all heard of scleral lens practices that have patients that fly in from around the world. So if you say, I can't do myopia management because I don't have a lot of kids. Well, I reject that premise. It's certainly easier if the kids live in your neighborhood. But all of you who practice this and do a good job of it have had patients drive miles or fly miles. We've had patients from the Caribbean fly up to our DC centers, and think of how many practices they passed over to get to Tyson's Corner, Virginia. So I really do believe you can add anything to any practice. The question really becomes, instead of can, is should you? Should you add it to your particular practice? And I'll give you some examples. Dry eye gets a lot of press. It was probably getting the most press up until myopia kind of knocked it out of the #1 position. And should you do it? Well, you obviously have to have a passion for doing it. You have to want to do it. Think about how few practices provide good low vision care. And the #1 reasons is the doctors don't want to do it. They think it's kind of a downer or subspecialty to deal with people who can't see well. But it's obviously a needed service. It's a greatly needed service. And those doctors that do it and really love doing it report incredible success. So dry eye, there's a huge population of patients who can be helped. We have the technology to take care of it. It's no longer just here's a bottle of artificial tears, here's a handful, pick one. Luxury eyewear is another one. Luxury eyewear is something that is a lot of us talk about. If I could sell a pair of glasses, a second pair of glasses at a high margin outside of a vision care plan, I can make a lot of money. That's true. In some markets it works, in some markets it doesn't. And in some markets that practitioners do this, people will drive miles. And what about selling glasses online? We all talked about it during COVID. Most of us started it and stopped it. And last but not least, is anybody here selling t-shirts in their practice? Now, I'm kind of tongue-in-cheek, kind of being serious. T-shirts, as far as I know, yet are not covered by any managed vision care plan. T-shirts have a high margin. They can have a high margin. If a t-shirt has a really nice legacy or kind of retro rock band logo on it, I'm probably going to buy it, and I'm probably going to pay way more than I should. And a very high percentage of the population wears t-shirts. So why don't we sell t-shirts in our practices? We certainly could. You can sell t-shirts with your practice logo on it, just like they do in a lot of restaurants. Well, should you? I don't know. It's a personal decision, but you certainly can. Now, there are benefits and risks to can and should. With any of these are benefits and risks. And what we need to talk about as we get deeper into this discussion, and we want to talk about how do we make the dollars make sense, we have to balance the can and should and the benefits and risks of adding anything to your practice, and in particular, in this case, myopia management. So let's use some of these and talk about what some of the challenges could be. Well, there's brand differentiation, which means because you add this specialty to your practice, you are different and you have augmented your services. Now, there's only so many hours in a day. There's only so many marketing receptor neurons in a prospective patient that if you position yourself as the dry eye guy, as the luxury eye guy, as the t-shirt guy or gal, as the case may be, then you have to be less of something else. So if you decide you want to do more myopia management, you keep amping it up, amping it up, amping it up, you will become eventually known as the myopia management practice. Now, in our DC centers, that's all that we do. That's by design. It's myopia management by design. We don't do any primary care. We don't see adults. We don't have eyeglasses yet, because in the US, we don't have anti-myopia eyeglass lenses. So there was no primary care practice that got diluted. In your practices, presumably if you're a primary care practice, if you do more dry eye, if you sell more luxury eyewear, you're going to sell less of other eyewear. And these are things that you need to consider. Is it going to make sense to bring myopia management into your practice? Because something's got to give someplace. And that relates to opportunity costs. There is a cost or costs multiple associated with bringing any specialty into a practice. And that amount of money comes from, there's two sources of this capital allocation that you need to think about. One that we usually don't talk about because we think about ourselves. If, you know, we usually think about, okay, if I want to bring in myopia, I have to spend money. I should dedicate a room. I have to buy new technology. Got to train my staff. I have to get my marketing game plan. What about your patients? Your patients have a fixed amount of money walking into your office. It's not endless. Think about when you go into a restaurant. When you walk into a restaurant, you have already made a decision to buy. It's very rare that a person walks into a restaurant, sits down, looks at the menu and says, nah, I don't think so. They've made that decision before they walked in. They went online, they saw what was available, and they see, I think I want to eat here. It looks like it's a good sushi place. I think I'm in. But they have decided to buy. Now, they have a certain amount of dollars in their head that they think it's going to cost. And when they walk into the sushi restaurant, they think, you know, I'm here with somebody else, two people in the sushi restaurant. I think this is going to cost me $50 by the time I leave. They have a number in their head. If they get a bill and the bill is $500, now that's a problem. First, let's hope that they can pay it, but they're highly likely not to come back. So capital allocation, your patients walking into your practice, and this is a big problem with those that dabble in myopia management, because the patients have an expectation coming in that I want to use my managed vision care plan, and I just want to pay the $50 copay, and maybe they'll try to upsell me to $100. And now you're telling me it's going to cost $3,000. And that's one of the key reasons that a lot of parents say no, is because you haven't prepped them with this capital allocation thought process. We just think about how much do I have to spend in my practice. Brianna spoke about planting seeds. Well, you got to plant the right seeds. And if you're going to talk about costs before the parents come in, you have to make sure you have the proper discussion so they understand before they come in. And then, as I said, there's your capital allocation. If you're going to spend the money on X, you can't spend the money on Y. So you're going to have to make a decision. Am I going to do myopia management, assuming you're doing neither right now? I'm going to do myopia management or dry eye or luxury eyewear or sell t-shirts. I have $10,000 to spend. I can spend it all on one, or I can divide it across. And the more you dabble, the more you divide, the more you're going to dabble, the more you're going to dilute, and the less successful you're going to be. Next thing for opportunity costs is labor. If you're going to go into a myopia management practice with the same staff that you have now, you'll be okay, but I would highly recommend you hire somebody new who is your myopia management specialist. In our centers, we call myopia treatment coordinators, MTCs, that you either hire somebody new, that's their reason for being in your office, or you find a way to take somebody who's under indexed in hours right now and give them more hours and let them be your myopia treatment coordinator. So the point is, if you do with the existing staff you have now and existing staff hours, while they are taking care of a prospective parent and explaining that, yeah, atropine is off label, but don't freak out about it, they are not selling a pair of progressives to the other patient who's been waiting for a half hour in the other room because you didn't allocate your labor spend accordingly. And last is space. We are firm believers, based on the data, that if you have a separate space in your office that is obviously set aside for myopia management, that you will do better than if you don't have such a space. Dry eye practices have done this. You've heard of the Dry Eye Center of Excellence, where doctors set up almost like a dry eye spot. that have done really well with this concept. And the same thing happens with myopia management, but there's a cost. If you allocate that space for A, you can't use it for B. You can't, if you have a fixed number of exam rooms and you can't decide between dry eye and myopia, and you want to build a room, it's tough to do both in the same room and do it well. And the benefit and risk is that you could make money or you could lose money. There's some risk in any of these, including some of the no-brainer ones like t-shirts, because t-shirts could totally dilute your brand. If you go into a highly medical practice and they're selling t-shirts, that's going to be a little bit weird, a weird mojo. That's a pretty extreme example to illustrate the point. So why myopia management per se, instead of some of these other subspecialties that I touched on? Well, here's numbers. These are the numbers in the United States of patients who have these conditions. And in some of these, I've been pretty generous. I went to cone head specialists, doctors who do a ton of scleral lenses. I spoke to glaucoma geeks when I put this together. And these are the numbers I came up with. The myopia number is probably even higher. This is based on old data, but it's the best data that we have. It's about 30% of kids in the US are myopic, and it's probably close to 50% of the entire population. And 98% of people in the United States wear t-shirts. So you have all these specialties. You don't have unlimited time to address all these specialties. So with that, you got to pick one. And you've probably heard this story before. Somebody asked Willie Sutton, he was a famous bank robber, why do you rob banks? And he said, because that's where the money is. So I'm speaking about having the dollars make sense in your practice. I don't mean this to be mercenary, but that was a topic that I was asked to speak about. And where does it make sense from a financial perspective? Well, go where the money is. And t-shirts would be my number one thing to think about. If that doesn't work for you because of brand dilution, then go to myopia. Now, I'm not saying these keratoconics should be ignored, but you heard about referring out to others. You are about 200 times more likely to see a myopic kid in your practice tomorrow than a patient with keratoconus. I mean, just think about that. And these keratoconic patients, they need specialty contact lenses, but do they have to get them from you? They need them. Somebody has to take care of these people. And very often a scleral lens is their last hope before sometimes a second surgery. But keep in mind that there's all these myopic kids who really need a lot of help. And you saw in the previous lectures that there are high risk for some pretty nasty stuff to lose a lot of vision. So it's really go where the money is. If you're listening to this presentation based on, does this make financial sense for my practice? Then I don't understand why I would put an inordinate amount of time and energy and capital outlay and patients' capital outlay when they can get these services elsewhere. Could you do all of them in your practice? Yeah, but you won't do them all well. The essentials to have a great myopia management practice, and this is really just based on, like I said, when I kicked this off, replicating this about 70 times across the country. This is not essentials based on one practice. You've heard this before, and it's, have a no dabble mindset, go 100% all in. I'm not the first person. I may have been the first person to say it, but not the first person today. And I want you to think about that. Like, why is this so important? And think about how many pairs of flat top bifocals did you dispense last month as relates to no dabble. Now, I'm going to hope that it's hopefully close to zero is the answer. But I want you to think why. And the answer to that question is when a presbyope walks into our practices, we instantly start thinking, the entire office, the receptionist, the insurance biller, people who may have no direct contact with this patient from an optical discussion standpoint, we immediately start thinking about high-end digital progressive lenses because we know they work. We have a lot of confidence in the optics that they're going to work, and we know what's best for the patient. And because there's this digital progressive mojo or a gestalt in the office, nobody talks about flat tops. Unfortunately, with myopia, with childhood myopia, when a kid walks in with a note from the school nurse that he failed the screening, or the mom said, he's squinting, he's doing this, and the doctor gets a gets the auto refraction, it says minus 75, or the technician looks at it, says minus 75. Most people are thinking, I wonder what managed vision care plan he has. We have to get this kid a pair of minus 75 eyeglasses. And that's a dabbling mindset. That kid who gets that minus 75, hopefully gets his axial length measured also. But that kid instantaneously, just like a presbyope getting a pair of progressives, all the logic switches need to go off that we're going to stop this kid's eye from getting bigger because he has this little minus sign in front of his autorefractor, and we can't let that happen. We can't let this kid's eye get bigger. It's already bigger than it should be. And that's a no dabble mindset, that everybody is in lockstep and we are going to do all we can to not let this kid's eye get bigger. The practices that don't dabble, I think like this, those are the ones that'll see at a minimum that will treat 5-6 kids a month, and in some cases 30-35 kids a month, depending on how much they've committed, how much resources, both physical and mental resources. And this sounds like it's kind of amorphous, but it really is the number one essential to have a great myopia management practice. You have to go in all in. I'm going to do this. I'm going to do this for real, and I'm not going to dabble. To kind of sum that up, there's a story that about John F. Kennedy, when the Apollo mission to put a man on the moon was in progress. Before they had done it, a couple of years before, he flew down to NASA headquarters down in Florida, and he walked into a nondescript office building, and he saw a janitor mopping the floor. And he walks up to the janitor and he says, "Sir, what do you do here? What's your job?" And you would expect he'd probably say something like, "Well, my job is to keep the building clean. To sweep the floors, clean up the bathrooms, clean the windows." And his answer was, "Mr. President, I'm helping put a man on the moon." If a patient or a parent comes into your practice with a kid and they say to your staff, "What do you guys do here?" What is your man on the moon phrase that you're going to say to parents? And when your office gets there, where everybody gets there, that's when you know that you're no longer dabbling, that you haven't figured out that everybody is in lockstep, and these kids' eyes are not going to get worse. And until you get to that point, consider yourself dabbling. I don't mean that in an accusatory way, but think about this from the perspective of what does your office do for these kids? And when everybody gets to that piece, in Brianna's case was her elevator pitch, elevator speech, describing what you do at its core, its emotional core, just a couple words, that's when you know that you're on the road to success. That's where you need to start. There are costs associated with myopia management in your practice, costs associated with anything. And one of the big ones is chair costs. And chair costs is something that a lot of doctors like to ignore it and pretend it doesn't exist, but it's really the biggest cost in the practice. The biggest cost is not technology. The biggest cost is chair costs, because it's relentless. It's there every day. It's there every second, and it never goes away. And a lot of us like to ignore it because we don't know how to figure it out. It's actually really, really easy to do it. All you need to do is print out your profit and loss statement, go into QuickBooks, print out your profit and loss statement, and take all your fixed costs. And the easiest way to think about fixed costs, there's a lot of formulas you can use, but a really easy way to do it, it's anything that is recurring. So things like rent, labor, insurance, which means anything that's not cost of goods related is probably closer to fixed costs. And for this exercise, that's close enough. The next thing is you take that number and you divide by a unit of time. And that unit of time, there's a couple ways you could look at it. It could be, how many exams did you see last year? Or how many exam slots, because maybe all your exam slots weren't full. So that would give you a number that it cost you $87 per exam last year. That's one way to look at it. You're going back in time. Or it's $100 per exam slot. So every time you don't fill that slot, the clock is still ticking, and that slot is costing you $100. That's one way to do it. Another way to do it is look at your appointment book and what do you have coming up for the year? How many slots do you have? Maybe you change your appointment template. and you have the same thing. Say this year, because my rent went up a little bit, my cost went up a little bit. I have to pay my staff a little bit more. My number of exam slots, now it's going to cost me $115 per exam or $128 per slot. Or another way to do it, the super easy way to do is how many hours are you open? And this way you just say, it costs me $150 per hour. I put the key in the door, I turn the key, and the clock starts to tick. It's $150 per hour, no matter what. And if you think of it that way, that helps you eventually, we're going to talk about fees, that helps you eventually get into a fee model that makes sense, because we spoke about capital outlay, how much you're willing to invest in this and how much you expect to get back. And this by far, with pretty much anything in a practice, this is the number one cost in your practice, because it's relentless. It never stops. The second you sign your lease on your practice and you put the key in the door, that clock just keeps ticking away. 150. That's why at the end of the year, you look at, wow, all this money came in the door and I only took home this much. Where did it go? This is where it went. Other costs that you have, chair costs by far number one. Marketing costs. Brianna spoke about planting seeds, right? That's a part of marketing. So having discussions, having materials, having information on your website, having your staff trained, that's that informational piece, pictures in the office. But, you know, you've heard planting seeds before. What seed are you planting? If you want to grow carrots, you got to plant carrots. You can't put a carrot seed in and expect to get a cucumber. So one of the reasons that doctors reject this whole, I want to invest in marketing, is because they have tried marketing before very unsuccessfully because they planted the wrong seed. So they'll say, you know, I put stuff on my website, put stuff on Facebook posts, I'm working on my SEO, and parents are still saying no. Well, what are you planning? What are you saying? What message are you sending out? And if you send out the wrong message, that's a problem. With regard to Ortho-k, I can share a little bit. We spend Treehouse Eyes, we spend tens of thousands of dollars on consumer research before we open the door to make sure we have the right message. And one thing we learned about Ortho-k in general was that parents were not terribly excited about Wake Up and See. They thought it was cool. Well, that's you know, I've never heard about that before. It's kind of neat. You put on a lens, take it off, wake up and see. And they were a lot more excited about, we can prevent eye disease in your kid by not having your eye grow so fast. We can slow down the rate of growth of the eye to what it should be, that's age appropriate. And they were much more excited by that. In fact, one of the Wake Up and See messages that we got from a parent was, she actually said to us, so wait a minute, so I can pay the doctor $3,000 to get these magical contact lenses I never heard of before, so that's a little bit of a scam. But I'll pay for these lenses. I have to fight with my son to put them on at night. I got to make sure he wakes up early enough so he doesn't miss the school bus to take them off. And that way he can wake up and see, or I can do what I've been doing, which is take him to the guy in the highway every year for $159 and get a pair of eyeglasses. I think I'll do it my way, because you know what? If he leaves his glasses on a nightstand and he puts them on, he can wake up and see. I never thought about that because as an OD, I was so blown away by peripheral defocus and corneal compression and all that sort of stuff. Parents' perspective of talking about the wrong message of freedom from eyeglasses. So, you know, that's an example that if you're spending on marketing and you're not getting a return that you like, it could be the wrong message. The next cost is staff. Now, staff is kind of inherent in share cost. And I believe when I speak to doctors, yeah, Gary, I'm having trouble hiring staff. Well, it's because, to put it bluntly, you're just not paying enough. The Great Resignation, in the land of optometry, I think is a fallacy. I think optometrists generally underpay, and they are paying for a myopia treatment coordinator. They're paying the same amount of money they would for other staff people in their office, when this might be somebody who should be the highest paid person in your office. You heard about Brianna saying FAQs. Well, it gets back to the same thing. Are they giving the correct answer to the frequently asked question? And are they able to deliver consistently? And if you don't hire appropriately and train appropriately and put the time in, and there's a cost associated with doing that. If you don't do that, they're not going to give the right answer to the FAQs. And they're not going to handle the patient with the same mojo, same brand mojo that you want, because you didn't hire the right person. And the last expense, which really is the least expensive, is the technology cost, because it's a one-time spend. Whether you buy an A-scan or you buy the most badass optical biometer, it's a one-time cost. You can pay for it monthly. It's incredibly inexpensive to get into myopia management. The technology cost is really, really low. The chair cost is high. The equipment cost is really, really low. And the thing to remember with all these costs is that regardless of what specialty you bring in, scleral lenses, dry eye, glaucoma, T-shirts, or myopia management, there's a cost for everything in your practice. So it's a question of where are you going to put that lever, where are you going to put that spend to get the most back? And I would recommend that regardless of what you do, whatever the specialty is, to allocate about, and you're going to think I'm crazy, but I'll back this up with some numbers, about 2 times your average patient fee per month is what you should be spending on all these costs. So for example, just to make the numbers easy, if you were charging a brand new myopia management patient, I'm not saying you should charge this. I'm not advocating fees. I'm using this as an example. If I said $2,000 is a pretty solid fee, I will want you to spend on all these things about $4,000 a month. And you would say, are you crazy? You want me to spend $4,000 a month? That's almost $50K a year just on myopia management. I want you to do that because if you spend the money properly, you only need to get about, if you spend 2 times, you only need to get about 3 times, three patients to cover that spend. And if you do a good job, you get these patients in perpetuity. They won't leave your practice if you do a good job. These are one-time investments in your practice. So you write that check once. If you're spending $4,000 a month, you write it once per month, and it starts to leapfrog into successive months to build your practice. It sounds like a lot up until you break down the math of what are you spending the money on. Your chair costs, marketing, staff, and equipment costs. So all these things together, if they came out with my example, about $4,000 a month, and you have the right spend, you shouldn't have to spend more, but you certainly can't spend anything way less than that. And as I said, you have these costs for everything in your practice, including primary care. It's not free to provide primary care in your practice. So you have to decide on the opportunity cost side, where are you going to put those hard-earned dollars and what has the highest likelihood of succeeding? And in my opinion, it's myopia management. I want to touch on fees to patients a little bit, and you see the Staples Easy button, because I'll tell you, no matter what you do, you want to keep the fees easy and understandable for parents, because one of the big dropouts, or one of the big reasons for saying no, is parents get blown away by these crazy matrices of fees. We have done inordinate amounts of research on fees. And I can tell you that the more complex it gets, the tougher it is to get parents to say yes. They're coming in, they already don't understand myopia management. Well, I haven't heard about this before. Why won't insurance pay for it? And if you come out and make it crazy, complicated to understand, now they don't understand your fees either. So you give them another reason to say no. I would recommend, if you go down this path, that you have one fee regardless of the treatment. Think of what orthodontia does. The orthodontist says, I'm going to charge you $6,000, and at the end, your kid's going to have a great smile. He doesn't say yet exactly how he's going to do it, he or she, how they're going to do it for your child, but it's one fee and everything's going to be covered. Just keep it easy. And keep these things in mind, that you have to set the fees relative to chair cost, equipment, marketing, as compared to doing these other subspecialties. And with regard to keeping it easy in a matrix, I would highly recommend, when I said one fee for everything, I would not charge more if the kid is more myopic, if his eye is bigger, if he has cylinder. I wouldn't do that, because parents told us in the consumer research, they felt like they were getting penalized because their kid's vision was extra bad, and they felt bad enough that the kid was myopic. The last thing on the topic of fees, actually 2 things. One is, it's generally easier to get patients across the finish line if you have a monthly fee instead of give me the whole thing now. And it's for a couple of reasons. One is they're used to paying monthly for everything, including the orthodontia. It obviously reduces the capital outlay. And keep in mind, these are the parents who very frequently never heard about this before. So you want to reduce the risk as much as you possibly can. So any way you can get the payments to be monthly out of the blocks, to say it's X dollars a month for the next Y months, as opposed to it's going to be $4,000 today. You can have higher uptake. When parents say no, what do you do? Do you stop and you say, oh, well, I guess I'll see your kid next year when his prescriptions is diopter worse? You have to realize that they're saying no, not because they think you're a con artist per se, but it is new and it may not be credible because of those seeds that you planted. It may not have been the best seeds, the best information that you could have given. So they want some time to digest and go to Dr. Google. And the way you combat that is you have to communicate with them a lot before they come in to see you and make it all new so it's not new. And again, this gets back to the exact content that you drip to parents. We use a video system to do it. It's incredibly effective. So when they come in, it's not the first time that they've heard it. The next thing is, I'm saying no because I want to speak to a real doctor. I want to speak to my ophthalmologist and my pediatrician. The best advice I can give you there is reach out to these doctors in your community. Don't try to make them myopia management zealots and supporters. Try to get them to neutral. Try to get them not to say no and it's dangerous and it's horrible. If you get them to neutral, where yeah, gee, I don't know, it's not really my thing. Treehouse Eyes knows more about it than I do. I've heard good things about them, but I don't really know too much about it. That to me is a huge win if you can get them there, away from no, atropine is dangerous, your kid doesn't need it, I'm myopic, I'm fine, I got through medical school and I'm a -10 and I'm fine. I told you I would give you the answer to this. We had a pretty good smattering of answers, and we don't have a drum roll, but if we did, I would be the best I can do right now. YOP is your optometry practice. Your optometry practice that does non-dabbling myopia management. Because think about if you were to spend 2 times the patient fee every month in any one of those stocks that I had listed, would you get a return that was anywhere near over 10 years, which you could get from continual investment in your practice done the right way? That's the key thing. The right seeds, the right messaging, the right training, the right clinical protocol. If you put the time into this, into your practice specifically, and I can say this with a super high degree of confidence. I've been consulting for doctors for almost 30 years. So I've looked at literally thousands of profit and loss statements. And when you do it the right way, when you're analytical, when you're scientific, Brianna spoke about getting into the tribes. When you go to VBD, our Treehouse Eyes guys, they have their own tribe where we communicate amongst ourselves. Regardless of how you do it, your local society, doing it the right way and not dabbling has an investment that will blow away Bitcoin, Apple, Walmart, Tesla. It's not even close. The numbers are crazy. What I love about it, it's all under your control. That's all I got. And Aaron, I'm gonna stick around. If you guys have questions for me, visit growmymyopiapractice.com if I don't have time to get to your questions now, and you can find a way where you can contact us. Thanks again for listening. Thanks for being here. And I appreciate the opportunity to speak to you guys.
Gary, that was awesome. We do have a couple of questions. What do you say to our colleagues who consider building myopia visits to insurance as opposed to keeping it private pay?
Well, right now, the majority of insurance companies won't pay for it. There are some managed vision care plans, I don't know if that's what they meant, where it's kind of left up to the doctor's discretion from a perspective of, they'll say like Ortho-k, for example, it'll cover some of the services, but not the materials. So I would, in our model, we do not bill insurance. If the patient wants to do it themselves, we give them an itemized receipt with the procedure codes, everything broken down. They can send it in on their own. But I would strongly recommend keeping this as fee for service and just telling parents it's not covered. And you typically with most insurance plans, you're going to be on pretty safe ground saying that.
Do you recommend a lower fee following the first year of myopia management?
So Sort of. What I recommend is you start out with a fee that covers at least 2 years of service. So again, I don't want to give exact numbers here because it's not appropriate, but X number of dollars for 24 to 36 months. And then after that, continue with a monthly fee that's going to be a little bit less, but still monthly. So the monthly fee keeps going up until the kid graduates out of the program, which is usually, late teens, early 20s.
Gotcha. All right. Thanks, Gary. That was awesome. Aaron?
Pleasure.
All right. Yeah, thank you, Gary, again for that fantastic hour. So this concludes the COAT part. So you all got your 3 hours of CE credit. We are going to jump into a panel next with all the speakers that have been presenting today. And Chris is going to run the panel. He's got a bunch of questions curated for this. And stay through the panel if you can, because afterwards we're going to have another $100 Amazon gift card raffle. So Chris, if you want to start taking over and launching questions at Paul, Gary, and Brianna. I'm not sure if Anith is still on. He might be. He is. All right. Yeah, Chris, I'll let you take it away.
All right, sounds good. So some questions is ProGent was brought up. I think, Paul, you mentioned it. We already asked that about letting patients use ProGent at home. So a question about ortho-k is, do you often find yourselves changing the optic zone, and what's better, smaller, bigger, why?
Well, it depends on what it is that you're trying to accomplish. If this is a kid, if this is a progressive myope, you want to go with as small a treatment zone as possible. You're going to probably induce a little bit of glare and a little bit of haloing. I find that most young kids don't really mind or are bothered by that so much. Once they hit 16 and start driving, sometimes you have to go with a slightly larger treatment zone, if you can. And if it's an adult ortho-k patient, then of course you want to try to go with the biggest treatment zone you can. When I say if you can, it's because the treatment zone is a little bit controlled by the amount of myopia that you're trying to correct. So if you have a highly myopic patient, -5, 6, 7, you're not going to be able to create a large treatment zone. It's going to be a smaller treatment zone.
Thing I'd like to add for that, especially with some of the custom designed ones, your back optic zone radius isn't a 1-to-1 ratio to the treatment zone. So you can have a 6.2 millimeter back optic zone radius, or diameter, I should say, but the actual treatment zone that you see on topography may be much smaller, because you'll see a ramp up into that reverse curve. So some of the other designs like CRT and Ability, a lot of those are a little bit closer of what the base curve diameter is to what the treatment zone is. But with some of these customized ones with OrthoTool, iSpace, and Wave, they'll ramp up a lot earlier into the base curve, where you'll see maybe a 6.2 millimeter base curve is actually getting a 5.5 or 5 millimeter treatment zone on topography. So something to keep in mind.
Awesome, great. And I'll go ahead and take over a question. I know Chris has to get going here. So let's see here. Any tips on kids with narrow apertures on getting good topo maps?
This is
Well,
an
you do the best you
interesting
can is my answer. You can sometimes you can use a staff member to with a Q-tip to kind of roll that upper lid up a little bit. Sometimes you can adjust their position by having them turn their head a little bit away, move their nose out of the way of the cone. But sometimes you can only do as much as you can do. Some of the Scheimpflug topographers, like the Oculus machine, for instance, can sometimes get because they don't get as close, so you can get a wider topography.
Yeah, be careful on that one too, because if you get a topographer, or if you get a topography that really shows induced astigmatism, we did it on a little kid last week, had 3 diopters of astigmatism that just wasn't there in the refraction. So if you get something weird, do it again. And it was because he was pressing so hard. And so you can induce astigmatism that's not there. So it isn't a really entertaining question.
Yeah, that's a great tip. Lubricate to avoid any dry eye artifacts. For lower lid, I like to have my staff kind of pull on the cheek, not right under the lid. So come down like this, and having 2 people sometimes is better than 1.
The other thing I can throw in a practice management side is have the parent do it first. And coach the parent to say like they're going to see something in here. Feel like if the kid is like a Disney fan or something, I'm going to look inside here. I'm going to see Mickey Mouse. And then the kid's going to say, I want to see, I want to see. And that can work all, especially with real little kids. You can fool them easier than the big kids.
PTS is still on. That's a good tip. Why don't you start having different targets? Mickey Mouse, Minnie Mouse.
All right, and we got a great question. This came up in the first session as well, but we'll go ahead and readdress it. For Ortho-K, do you price the fit separately from the lenses, or do you do a global price? The big
It's a
question about the
It's a
global
program fee. It's a program fee. There's no reason to separate the parts and the labor.
Do the same.
I think we're all
Same.
are we all in agreement on that
Yep.
one? Yeah. Okay. Awesome. Let's jump over to this question. Is there a timeline for spectacle myopia control in the US? Do you have any info on spectacle efficacy versus other myopia management options?
I can jump in. We're in contact with the manufacturers. So as much as I'm allowed to say, it looks like probably end of next year, beginning of 2024 is where we'll see them. Efficacy looks really good. Depending on the exact lens, 60% or over. And then the whole issue, now should we be talking about percent or care values or everything else? But if we're going to use percentage relative to other things we're familiar with, like atropine or ortho-k, it's about 60%, which is pretty good for an eyeglass lens. I don't think there's any data yet with eyeglass lenses and atropine, but I think that there's a possibility if you combine the two of those, assuming they're different mechanisms of action, you get even better results.
Yeah, any other panelists that have anything to add to that?
I would just also look at who's gotten into the space. It is every major manufacturer, and they're really doubling down on this. So I think that this is a space that we should own and get to own, and it's a huge opportunity.
Yeah, and I agree with Gary. The studies out of Europe seem to be very promising, and 2023, 2024, exciting. It's coming up.
Definitely. I think it definitely is going to add a different dimension to every practice that does myopia management and control. All right, another question here. What are your thoughts on 0.05% atropine, starting with that instead of 0.01%?
Well, since I talked about this, so looking at it, it's really case specific. So remember, on a blue-eyed baby, 0.01, 0.025 may work, because we live in a generation where kids are not going to complain, and the parents aren't going to put up with complaints from the kids. So if you have a kid that's complaining that they're not seeing and all of this, you're going to derail your treatment. So you want to just get right to there for success, because we don't live in an environment where you're going to do it, right? They want to pave the road for all of these little kids. So you got to be conscious on what you're doing there. They just won't do it. Anything else anybody wants to add on that sentiment?
I probably do atropine a little bit less than both you guys, but I like to start at the higher percentage when I'm using it and then taper down if need be. I think a lot, LAM2 have shown the efficacy of 0.05 with minimal adverse effects. So I like to always start there. 0.01 has shown in combo treatment some effectivity. But again, with axial length, it's not as beneficial in a lot of the studies. So I like to start with 0.05, and I think a lot of the studies back that up. But that's the other thing, is you got to go case by case, like Brianna said. You know, like some of the studies are limited in what they're looking at. So you might see clinical success that some of the studies didn't investigate. So you got to keep that in mind. But for me personally, I like to start higher and then go down if need be. Gary, what about you?
We use the opposite approach. Because we want to give the kid as little drug as possible that works. So, but we don't start with 0.01 because we're all pretty convinced that just for axial length doesn't work. So we typically we have a proprietary algorithm that we use. If the kid comes in with X, start with Y. And if it points them to atropine, most of our doctors will start with 0.025. If there's a lot of risk factors, if the kid's already got a 27 millimeter eye and his mom's a -10, female, Asian, nerd, I mean, all that stuff, then we'll go 0.05. But most of the kids will start at 0.025.
Yeah, 0.025 has pretty good results. It was the 0.01 that really a lot of studies kind of showed too.
Right.
Not as beneficial.
All right, great. Another question, I'm going to combine these two questions. What service do y'all use for monthly billing? Do you have something like CareCredit or, Sunbit or something like that in your practices?
Yeah, I learned early on, I am not a bank. So if you can break this out in easy to swallow payments, it's better for the patient. So versus giving them a high number, you can say, for only X amount a month, this is what we're going to do for your child. So that's been beneficial to have that. So there's many different out there that you can utilize.
We use CareCredit. If we have a parent who says, is it a hard credit hit and is it another credit card? Because if it is, I don't want it. We will offer in-office financing, or it's in-office discount actually. And anybody here who has a credit card swiper in a machine or Insta or a tap, whatever you have in your office, also has the ability to do recurring billing through a website. So whoever your provider is that gave you the box, you can call them up and they can show you how to do recurring billing. You're certainly taking a risk, no question about it. But the data is pretty good that the difference in the merchant discount, you're probably going to come out ahead even after you account for taking some of that risk in your practice. It bangs up your cash flow pretty good. I spoke about share costs. That's a downside of doing it. The upside to CareCredit is you get paid in full, minus the chunk that they take. So I would, we've had great success with them. They've been easy to work with. So I would start there.
Yeah, we use CareCredit and Sunbit, which is another company that does it. It's a soft credit hit. You do pay a monthly fee in addition to the hit. But it's been really easy to use for patients. And just like Gary said, we also offer an in-office, basically monthly payment plan through our merchant service. So you take the risk of it, but it's just easier to say to the patient, hey, we'll help you out no matter what. And it's a small percentage of patients that utilize it and we haven't gotten burned yet. It's just better to offer that to the patient and not have any issues, kind of limit the barrier to entry.
I want to jump in on this too. We do it pretty much the same way as everybody. We do offer a prompt pay discount, if they pay it in full, or we'll use our office, our credit card machine company to do a monthly draw. But you have to be careful if they want to use their flexible spending card because, those are all based on date of service. So it can get a little sticky when you're doing a monthly swipe on a flexible spending account. So just try to understand those rules.
All right, great. And then one last question before we wrap it up. I know it's been a popular question. Combining atropine with either soft contact lenses or ortho-k, what's your all's protocol for that? And when do you do that, or if you do that?
Well, I'll jump in here and I'll tell you that if I'm not getting enough control with my either soft lens or ortho-k treatment, and I've done everything I can to kind of adjust for that, then I'll add some atropine to it. At least as far as the ortho-k goes, if you have a kid with small pupils, you might benefit by widening out those pupils a little bit and try to get that red ring inside that pupil zone. So, it's a perfect example for combo therapy.
Aaron, we're going to release our camp study data pretty soon. It started with 1,500 kids. We looked at over about 3 years, got down to 342, met the inclusion criteria. And to answer your question, about 15% of them are in some kind of combo therapy.
Yeah, I think it's definitely becoming more sought after too, because if you can get one control and add a little bit more, 10 to 15 to 20% more control in a dual treatment, it might be worth it. So again, I think it comes down to looking at the full visual system, which is axial length and refraction, and seeing what you need to do for these little ones.
Yeah, and the other thing that's important with combo therapy, and it kind of relates to what everybody said here when talking about don't dabble, like you have to have all the tools available to do this well. And that means that you have to have inside your FAQs, well, why do I have to add something? What's going to happen with the fee? Is it going up? Is it going down? What if you start with atropine and add a contact lens versus the other way? Is there an additional fee? So you have to have all that in place first with a staff that really is confident with the answers. And I would do all that before I do anything with combo therapy to make sure you have all the infrastructure in place, codes in your EHR, all that sort of stuff, billing billing codes, things for like, when does the kid come back, or they now want an atropine recall or a soft lens recall. All that has to be buttoned up before you go down a path, but you have to have it in the toolbox.
Don't make the expensive mistake I think every single person on this call has done, going in tomorrow and thinking that you're ready. Just take a week, get all this out. It's totally possible to get this program built really quickly. This is not a high mountain we're asking you to climb.
One thing I'll say about combo therapy, and I don't do a lot of it, but it'd be tough for me to make a decision to add atropine on top of ortho-k specifically without measuring axial length. But that is my go-to, saying, hey, if the axial length is increasing with my ortho-k treatment, that's what I'll go by to add a combination therapy. I think just going by refraction with these young kids is, I don't know if I believe it enough to add a combo therapy.
And one thing too, I'll add, is because we live in Florida, so it's pretty transient. I've had some people that are moving out of the state or moving into the state. And what I'll do is, if I'm going to transfer care to somebody, I call offices myself. Hey, do you practice myopia management? And the responses that I get are really, really, really bad. Oh, hold on, let me see if I do that. If we do that, that doesn't sound like you do myopia management. And then I'll go another step and ask them if they have an A scan. Well, hold on, I don't know what that is. So your staff really is a part of this in your success. So be careful how they're answering the phone.
Or not answering the phone.
Exactly.
That could be it too.
All right, fantastic. Any closing words from our panelists before we end the program for today?
Well, I hope everybody enjoyed it. I think this is kind of a sneak peek of what Vision by Design can offer. The amount of education that you get there and how it can really up your game in myopia control in all modalities is really incredible. So I encourage everybody to join us in end of September.
Should use that code too and scan that QR code. All right. Well, thank you, panelists. And also want to thank all the sponsors today: Coopervision, Done For You Marketing, DGH, and Precision Technology Services. Once again, if you want to learn about any of those, feel free to scan the QR codes that are present. And it's time for our last raffle before we jump off. And our winner is Bilal Ismail. So Bilal Ismail, if you can email us, admin@ODsonFinance.com, you have won a $100 Amazon gift card for learning about myopia management. All right. Well, once again, panelists, I want to thank you again and speakers for presenting fantastic lectures, and they really built upon what we did about a month ago. I think this is great info that we've gotten out into the community. It's 6 hours of Code Group C and a few other lectures as well. So thank you, and hope to see y'all at Vision Expo and Vision by Design coming up soon.
Great.
We're going to
Thank you,
sign off
everybody.
for today.
Thanks, everyone.
Thank
Thanks,
you.
guys.
All right. Thank you, everyone. Take care. Have a great Sunday, and we'll see you at the next event.
All right. Thanks.
Bye.